Hello, doctors. Good afternoon. I apologize for the delay. Sorry, I just had to sort out one or two things. Please, can we see my screen? Hello? Okay, thank you. Yeah. So, we are going to continue today by um by looking at cytomegalovirus. So yesterday we stopped at HIV. So we covered everything about HIV. So today we are going to continue with cytomegalovirus. And this is one common infection in the United States. So most of the time, people with this infection, they are asymptomatic, or even if they are going to be symptomatic, they will just have this infectious mononucleosis-like presentation, you know. And it's also important to note that most people with CMV infection are immunocompromised. So um, it occurs in people that are immunocompromised either because they are receiving an organ transplant, or probably they have HIV, or maybe some form of malignancy or something that weakens their immune system. So watch out for that. It's a problem of people that are immunosuppressed. How do they transmit cytomegalovirus? How has it got it? You cannot forget this. Cytomegalovirus can be transmitted through any possible means. It could be sexual contact, sharing body fluids, organ transplantation, breast milk, respiratory secretion. So it has like a lot of ways you can transmit it. Blood transfusion, exchange of body fluids anyhow. Secretions can transmit cytomegalovirus. So it's very, very common in people that have CD4 count less than 50. Just like Mycobacterium avium. So people that have HIV with CD4 count less than 50, they can get reactivation of the cytomegalovirus and start presenting with some clusters of infection that we're going to talk about shortly. So don't forget the fact that it can resemble infectious mononucleosis from EBV rather. And we said that what you are going to do to differentiate it is to do the heterophile antibody test, which is going to be negative, in people with cytomegalovirus infection. So it can affect different organ, and the common one is the CRIP, which is the C for the colitis, the E for the retinitis, the E for the encephalitis, the next E for esophagitis, and P for the pneumonia. CRIP. So for the retinitis, it can cause retinal detachment. The retinal can detach from the underlying layer, and they just notice sudden blindness with floaters. They just tell you that they are just in floaters. So that's very, very, or like cotton is drawn over the eye. That's very common with retinal detachment. And if we do a fundoscopy, we are going to see the pizza pie appearance. I think I have an attachment here that illustrates that. And it's just areal of cotton wool opacities surrounded by hemorrhage. So we look at this. These are the like white opacities with areas of hemorrhage interspersed in between them. So this is more like, if you look at this section now, it looks like a pizza cut. So this is what we call the pizza pie appearance, and it's classic for CMV retinitis. Very common in people with serious immunosuppression, as low as CD4 count less than 50. They can have GL and hepatobiliary involvement. So it can affect the liver, and they start having elevation of the liver markers. They can have GI problem if they just start complaining of nausea, vomiting, diarrhea, which is bloody. So you seeing somebody with abdominal pain and bloody diarrhea, think about, and the person is having immunosuppression, HIV, think about CMV to be involved. Also, they can cause, esophagitis. So they start complaining of difficulty swallowing, painful swallowing, and they do the scope. We are seeing like linear ulcers, in the distal esophagus. Think about CMV esophagitis. They can have pneumonia. And don't forget, this is going to be an atypical cause of pneumonia. So their whole pneumonia is not going to be like that of strep pneumo, Haemophilus, um, influenza and all those things. So their whole pneumonia is going to be atypical, in which there's not going to be any productive cough. They are going to be coughing, but it's not going to be productive. You know, there could be fever, malaria and all those things. And by the time we are doing the X-ray, we are not going to be seeing any lobar opacity. So it's going to be likely interstitial opacities that we are going to be seeing. So there's going to be cough, fever, but sparse sputum. You see, as basic as it sounds, it is a very, very fast clincher to quickly narrow down the potential organism. By the time you look at the cough, is it productive or not? You can tell the most likely cause of that pneumonia. So, seeing somebody with HIV having pneumonia, you want to think about PCP, you want to think about CMV, to narrow down the cause. So, it can also affect the CNS, in which they can have polyradiculopathy, start complaining of tingling sensation, and also like maybe like pain radiating to maybe the leg and some part of the body, and they can also have transverse mellitus. Most of the situation of transverse mellitus follow like infectious causes. So they can say that there is complaint of sensory loss, motor loss, within a particular segment of the lower limbs. They have problem with bladder control, bowel control, and there's a sensory level. So that means that below that certain level, they don't feel any sensation. So you think about travel. So somebody having lower limbs, motor problem, they cannot walk. The lower legs, they are weak, they cannot walk. Versus having like sensory level at a particular portion. So if this is um if this is so sorry about this. This is the spinal cord, this is the legs, let's say that this is the legs, yeah, and this is like the upper trunk. So if they tell us that, you know, from this level downward, they cannot feel sensation, that's the sensory level. Think about transonalitis. The person having motor weakness, the lower legs, cannot walk, difficult to move, transverse mellitus. Bladder control, bowel control, transverse mellitus. So they can also have encephalitis, and one of those things you are going to see on imaging is periventricular calcification. Anytime we see anything periventricular calcification, think about CMV infection. Think about CMV infection. If you see periventricular plaques, think about what condition is that? Anybody? Periventricular plaques. Which one is
Multiple
that? Multiple
sclerosis.
sclerosis. So all those things, those buzzwords, we need to know where you find all those things. So um, if we do, we can do so many things to make the diagnosis. So we can do like isolation, just culture it. You do like histopathology, you do like a biopsy sample, and you look at it under the microscope. So usually you see like the whole high appearance. So that's one of the common things about CMV. You are going to see this whole high appearance on your biopsy. You can do a PCR to look at the gene, of the virus. So of course, CMV is a DNA or RNA virus. Anybody? Is it DNA or RNA? Microbiology. It is a DNA virus. Why?
DNA.
Because it belongs to the family of the herpes
DNA.
virus. So it's human
Mm.
herpes virus type 5 is CMV. So that's DNA. So how do you treat? Don't forget the ganciclovir, or you can use ganciclovir or foscarnet. You want to avoid this because of the renal complications and electrolyte derangement, but most of the time it doesn't get to this. So just remember the ganciclovir, or val ganciclovir. Anyone you see, just pick it. You're going to be correct. So I don't know. Do I have any any question here? Let me see. Okay, so this is a 45-year-old woman who comes to the emergency department due to 3-day history of fever, malaria, progressive dyspnea and exertion, dry cough, abdominal pain, and watery diarrhea. Her loose stool this morning were accompanied by bright red blood. The patient underwent allogenic renal transplantation 6 months ago, and she's currently taking tacrolimus, mycophenolate, and pred. 2 months ago, she developed severe leukopenia, which resolved after discontinued trimethoprim sulfamethoxazole and vancomycin. She does not use tobacco, alcohol, or illicit drug. Temperature is 38.9, blood pressure is 110/70, pulse is 114, respiration is 22. Physical examination shows bilateral lung crackles and diffuse abdominal tenderness. Gross blood is seen on rectal examination. Lab is as shown. hematocrit 30, platelet 118,000, leukocyte 38,000, leukocyte 3,800. Urea, nitrogen, creatinine is normal. There is elevated alkaline phosphatase. The liver enzymes are elevated. Urinalysis is normal, and chest X-ray shows bilateral interstitial infiltrate. Which of the following is the most likely cause of this patient's current symptoms? So, which one are we picking? These are the answers. So this person is having dysentery exertion, fever, dry cough, abdominal pain, and watery diarrhea. Now, the diarrhea became bright red, this morning, and she had received a renal transplant before. She's currently on some immunosuppressive and steroid, and now she had leukopenia like 2 months ago, and she stopped taking Septrin and vancomycin. She's still having fever right now, and there's elevation of liver markers. There's like leukopenia, platelet count is very low, thrombocytopenia, and X-ray showing bilateral interstitial infiltrate, with elevated liver markers. So what do we think?
CMV.
CMV. So everything is pointing towards CMV. Everything is pointing towards CMV. So affectation of the liver, affectation of the GIT, which is the reason why she's having like bright red blood, and it's because she has stopped taking this. So X-ray is showing features of pneumonia too, which is the bilateral interstitial infiltrate. So PCP will not be able to explain the diarrhea. It won't. So CMV can explain everything. Okay. So a previously healthy 28-year-old woman comes to the physician because of low abdominal pain and prolonged vaginal discharge for the past 5 days. Menses occur at irregular 20 to 40 day intervals and last 4 to 8 days. She's sexually active with a new partner whom she met 3 months ago, and they use condom inconsistently. She has a normal pap smear 5 months ago. She drinks 2 beers every other day. Temperature is 39 degrees Celsius. Examination shows low abdominal tenderness and bilateral inguinal lymphadenopathy. Pelvic examination is notable for uterine and adnexal tenderness and small amount of bloody cervical discharge. Laboratory study shows leukocyte of 14,005. ESR is 90. A spot urine pregnancy test is negative. An endocervical swab is obtained for NAT. The patient is started on ceftriaxone, doxy, and metro. Which of the following is the appropriate next step in the management? Anybody?
HIV test.
Why?
HIV test.
Why?
Because of the STI in the patient.
Because of what?
The sexually transmitted infection in the patient, the
Nice.
STI.
Mm-hmm. So anybody that have STI, we always say that we have to rule out, HIV. So it's part of what we talked about yesterday. Let me see this. I have a lot of questions here. Okay. Let's look at this one too. Okay. A 45-year-old woman comes to the office due to a month of intermittent bloody diarrhea and abdominal pain and 4 kg weight loss. The patient has no other symptoms. She was diagnosed to have HIV a year ago after several years of IV heroin use. The patient does not take antiretroviral treatment consistently and no longer use recreational drugs. Is currently engaged to an HIV negative woman, and the patient has never traveled abroad. The temperature is 38 degrees Celsius and the mucous membrane are moist, moderate cervical lymphadenopathy is present. Abdominal examination shows mild tenderness in the left lower quadrant. Lab results are normal except for CD4 count of 28 and a potassium count of 3.2. What is the most likely cause of this patient diarrhea? Anybody? This one is very easy.
Maybe Mycobacterium avium complex.
Yeah. Somebody said CMV. Did we say CMV?
No, we say Mark.
No, G.
Mark.
G.
It has to be Mark. So you can see CD4 count less than 20. She's having like, abdominal pain and diarrhea. They didn't tell us that diarrhea was even bloody. So this is more
Wet nose.
likely to be MAC. This is more likely to be MAC. Yeah, I agree with you. Okay, let's look at this one. A 34-year-old man with AIDS come to the physician because of 2-day history of decreasing vision and seeing dark spots in his right eye. There's no pain and the left eye is asymptomatic. He was treated for fungal esophagitis 6 months ago with fluconazole. He was diagnosed with Kaposi 2 years ago. Current medication includes efavirenz, tenofovir, emtricitabine, azithromycin, trimethoprim, sulfamethoxazole, and multivitamins. Why are they placing this guy on azithromycin? Anybody?
Prophylaxis for MAC.
Prophylaxis for MAC. Thank you. BMI is 16. Temperature is 37. Examination shows cervical lymphadenopathy. There are multiple volaceous plaques seen over the trunk and extremities. Fundoscopic examination shows. Anybody knows this? Multiple volaceous plaques. What's the diagnosis? Yeah?
Kaposi.
People are ready.
Sarcoma.
That is Kaposi sarcoma. So, fundoscopy examination shows granular yellow-white opacities around the retinal vessels and multiple areas of dot blood hemorrhage. CD4 count is 34. Which of one is most likely diagnosis? Which one is, what is this one? CMV retinitis. CMV retinitis. Very simple. CMV retinitis. Okay, so expect a lot of HIV related question in your exam. I can tell you for free, you will see it. They will bring it. HIV related problems, it will be there. So we have to know it. So central line arterial bloodstream infection, we call them the CLABSIL. So they are infection that happen or occur after within 48 hours of setting, the central line. So it's much more common in central line that are inserted into the veins more than the arterial one, and even more than the peripheral one that we set in the arteries in the limbs. So the notable risk factors include emergent placement. Yeah, so if you just do it quick, there's a high risk that's going to get infected. And the closer you set the line to the perineum, the higher the risk of it getting infected. So femoral line has a higher risk of getting infected compared to the jugular than compared to the subclavian. And also the type of the line that you put in also matters. So if you put in a non-tunneled catheter, there's a higher chance of it getting infected than a tunneled catheter. So if it's non-tunneled, that means it's outside in the skin. If it's tunneled, that means you have tucked in through the skin. So let us look at an example to just show you what I'm talking about. So tunneled, versus non-tunneled catheter. So there's usually one typical image that we usually use like that. And let me see. There's one image I usually use. So this is an example of a tunneled one. We can see that this is tucked through the skin. So this is where it enters into the internal jugular vein. This is the exit point. So for the non-tunneled one, you just see it naked outside, so let's see. Yeah, this is a very good example. This is what I'm looking for. So we can see that this one is running through the skin, tunneled through the skin. This one is outside. So this one has a higher chance of getting infected compared to this one. So, and it costs, healthcare like 46,000, nobody's going to be asking us that. So what are the organisms involved? So you always want to remember the staph. They are very common. The Staph aureus and the coagulase negative, particularly Staph epidermidis. They are very, very important. You want to remember Pseudomonas. You want to remember gram-negatives like Pseudomonas. You want to remember gram-positive like Staph. Staph aureus usually is one of the common, gram-positive. Then you now remember the gram-negative rods like Pseudomonas, Kleb, E. coli, and the other one. There are also extreme cases like fungi particularly people that are immunosuppressed, they can have fungal, infection. Some people can also have the enterococcal infection. So people that have enterococcal fungal staph, particularly MRSA, all those kind of people, once you are able to culture that in that line, the best approach is to remove that line, because it's very difficult for you to be treating enterococcal, infection, MRSA, and fungi. They are very difficult to treat. So once you culture it within the line, you want to remove it. So how do they present? So somebody with Klebsiella, what do you see? So just the cardinal side of inflammation, you will notice that there's going to be like discharge from that area. There's going to be erythema. That area is going to be very painful. It's also going to be tender when you touch it. So, and you're going to see like purulent discharge. So that's, those are potential, evidence to infection at the catheter site. So the person can be also having some systemic presentation, like having fever, having chills, rigor, and all those things. It can get bad that it disseminates into the blood, and the person can now develop septic shock. So in that state, it can lead to like autosensorium, hypotension, tachycardia, and all those things. So for the tunneled one, they can have all these things that we have said, and you'd also notice that there's going to be purulence at that site where you are removing, like the escape side of the catheter, where it's leaving the skin. There's going to be purulent discharge. And if you touch this site where it's tunneling, if you palpate through this site, it's going to be very, very painful. You know that, oh, there's an infection along this tract into the blood. That area is getting infected. So when you touch along that subcutaneous tract, it's going to be very painful and purulent. So what do you do? Of course, you know that there's an infection. So you want to make your diagnosis and be sure that that infection is actually coming from that side. So what you do is that we take a sample from that catheter site, and we also take a sample from a peripheral site. Then we subject that to culture. Then we also do some ancillary investigation depending on the presentation. So you want to obtain basic ones, like obtain like a complete blood count. If I got into like septic shock, you want to do like electrolyte urine creatinine to see if the liver, the kidneys are affected. You also want to do like liver function test. You want to do a ESR, CRP. Then you now wait for your result of your culture. So you need one of these three criteria to be met before you can say that, oh, this person is having Klebsiella. Now, what's the first one? Are you isolating the same organism when you culture the specimen from the central line and also the sample obtained from the peripheral line? Culturing the same organism, and do you have more concentration in the central line? That is one evidence. Another evidence is you are culturing the same organism, but you notice that you have like more than 15 colony units in the one you are obtaining from the catheter. So if you culture the same organism between the central line and the peripheral line, you culture the same organism, staph, both of them. But the one in the central line, you are obtaining like 15,000 colony units. That's another evidence that supports your diagnosis. And if you are culturing the same organism and you have like faster results, in your central line compared to the peripheral sample, like at least 2 hours earlier, you can also say that this person is likely having like Klebsiella from that central line. So we don't really need to memorize that. It comes to us naturally on the question, so we'll be able to pick it. So the question is going to spell it out, and they are going to tell us. So for the tunneled one, just like I've said, there's going to be pain, tenderness along the subcutaneous tract, and you're going to see like exudate from that area. And of course, all these ones too is going to be positive there. So how do you treat? The basic thing you want to do is, once you have, obtained your sample for your culture, you have obtained your blood specimen for your CBC, ESR, and all those things. You want to commence the patient immediately on broad spectrum antibiotics. Want to start broad spectrum antibiotics immediately, and you are not going to change, depending on what you get from your culture result. So if you get MRSA, you want to like switch to like Vanco, linezolid or something to just take care of that. If you grow Pseudomonas, you want to go to anti-Pseudomonal agent, piperazine, tactobactam. If it's fungal, you want to go to your fluconazole to treat it. So, and there are some conditions that necessitate removal of the catheter. You cannot salvage it. You need to take it out. So most of the time you can salvage the non-tunneled ones. So the ones that are outside, you can still salvage them, provided that you give the person a very superb antibiotic cover and there is no evidence of infective endocarditis. Because one of the complications of CLABSI is what? Infective endocarditis. So they can develop infective endocarditis because you can have all these vegetations in that. You can have the biofilm in the catheter traveling, to the heart, and they can settle on the valves, the endocardium, and cause infective endocarditis. So once you have that, that's already evidence of metastasis. So you need to take it out. If you're having septic emboli already going to other part of the body, you need to take it out. So if the person is having like septic like thrombophlebitis or like thrombophlebitis like inflammation of the vein, and there's now occlusion of the vein by a thrombus, a thrombotic thrombophlebitis, you can identify that by doing like ultrasound or CT. Once you see that, you also need to take that in out. And if somebody is having like a non-tunnel catheter infection, and from your culture result, you are growing like MRSA, growing like Candida, growing like Enterococci, all these organisms are very, very resistant to many drugs. So you might need to consider taking it out. So, but if all these ones are not present, you can salvage it and just place on antibiotics. But all tunnel catheter that is infected, once you have put it underneath the skin to protect it from infection and it's still not getting infected, you cannot salvage it. You need to take it out. You need to take it out. You need to take it out. So let us see one or two questions about that. So 4 days after undergoing a transradial amputation of the left forearm following a crush injury in a workplace accident, a 29-year-old man develops fever and hemodynamic instability. His post-operative cause was uncomplicated. His current medication includes morphine and enoxaparin. He has a central venous catheter inserted in his right femoral vein and a padded compressive dressing over the amputation stump. His temperature is 39.2, pulse is 113, respiration is 20, BP 80, and oxygen saturation of 96. Cardiopulmonary examination shows no abnormality. Examination of the amputation stump after removal of the dressing shows erythema extending up to 1 cm around the surgical suture, but no induration, swelling, discharge of crepitus. Purulent discharge and fluctuant swelling are seen at the exit side of the femoral catheter. A swab of the purulent discharge is collected and blood samples are drawn simultaneously from the femoral central line and the right cubital fossa. Which of the following is the most appropriate empiric antimicrobial pharmacotherapy for this patient? Okay, I'm not really sure I mentioned it. But what do we think? What do we think we might likely pick? Let's just make a guess.
Okay, guess C. I'm sure.
I'm happy that this question is coming up. Somebody's asking a question. Someone wants to ask a question. Okay. So what do we think?
C.
C. That's a very good one. So this is going to take care of what's it called? Which
So,
one? MRSA, right?
right.
This is going to take care of
MRSA.
fungal, and this will also take care of the other, maybe Pseudomonas or something. Your Sevapam is going to take care of it. So this is a very good, drug therapy to consider. So if you now culture, you grow, you can have discontinue that, okay, I won't need capsule, I won't need this. So that's just the way to look at it. So that's a very good, attempt at that question. Yeah. So moving on to thermal dysregulation. So we have hypothermia. Hypothermia is just defined as body temperature of less than 35. So once somebody have a body temperature of less than 35, we say the person is hypothermic. And it's good to know that shivering begins whenever the person is less than 35, but it stops once it's less than 32. So there are like three extremes with respect to hypothermia: 35, 32, and 28. So once the person is less than 28, the person is definitely going to be in coma. We can be sure that this guy would be in coma if he's less than 28. So if somebody is between 35 and 32, that's like mild form. Moderate if it's between 32 to 28, and less than 28, that's severe form of hypothermia. So here, 35 to 32, they'll be shivering because they want to increase contractility of the muscles to raise the body metabolism and increase the core temperature. So by 32, the body is already getting weak, all the processes in the body is shutting down, so they can no longer shiver again. So that's the time that they start having some symptoms, which I have here. I have it here. So they start hyperventilating, they are bradycardic, they have like features of CNS depression. So they are hyperventilating, they are getting tired. So they are bradycardic. They can have arrhythmias, you look at the pupil, it's appearing dilated, those are the things we see, at that stage. So it can now progress to the final stage where they now become like confused totally, altered sensorium. They can be having seizures, at that point too. So once it's less than 28, it's very, very bad. Very, very bad. So what do we do? No, sorry, before we get to what we do, it's very unlikely that they are going to be asking us that what is the stage of what stage of hypothermia is this? We just need to know the symptoms collectively. If somebody is shivering, we look at the body temperature less than 35, less than 35, it could be 32, 28, anyone. They are appearing confused, they are weak, they are having arrhythmias, they are like, bradycardic, okay, this is likely to be complication of hypothermia. So what are the potential causes? It could be from heat loss. Maybe they are exposed to like cold environment. Maybe the person drowned in the water. It could be from burn injury or trauma. We know that people that suffer burn injury, there's loss of the skin layer. So heat can easily disseminate from the blood outside. So they are losing heat, they become hypothermic. People that suffer trauma, they are losing a lot of blood. And blood is what helps us carry heat through the body. So losing blood, trauma, hypothermia. So it could be from impaired heat generation. All these three endocrine conditions, have one thing in common, and that is low metabolism. Hypothyroid patients have low metabolism, same with adrenal insufficiency, because cortisol is very important for metabolism. It's part of those hormones that is released even as metabolic response to trauma. You have it acting, metabolizing all the glucose, everything in the body to get the thermal energy in the body increased. So people with hypoglycemia too, there's nothing to be burnt. Definitely the person is going to hypothermic. So it could be from impaired regulation. So this is more likely to be from CNS problem. Remember all those nucleus in the hypothalamus, the AC, the PC nucleus that helps to regulate temperature. And of course, somebody with spinal cord injury too, the sympathetic tract are taken off. So you don't have anything that can drive that adrenergic response to increase body temperature. So they can be hypothermic. So what we normally do, regardless of the etiology, the first thing to do is just to, if the person is drowned, take the person out of water. If the person is not drowned, but the person is hypothermic from other things, you can just, remove their wet clothing. For example, if it's still drowned, remove their wet clothing. But if it's not from drowning, just give them like some blankets to just cover them. So we have like the response based on the temperature. So if it's between 32 to 35, we know that this is going to be like mild. So what we do is passive external rewarming. And if you look at the combination of the words, passive external rewarming. So when you say passive, it means that the heat you are delivering to that body, you are not the one delivering it. The heat in that is getting to the body is not from you. You are not delivering it actively to it. Probably you are just covering the person with clothes. It's not as if I'm forcing it to him. I'm just preventing further loss of heat from that body. So covering with like blankets, removing wet clothing. So those are like passive mechanisms, and it's external because it's coming from outside. I'm covering with clothes. I'm removing clothes. So that's wet clothes. So that's passive external rewarming, because at that stage it's not too bad. But at 28 to 32 is now moderate. So I'm not still going to go inside. So it's still going to be external, but I'm going to do an active approach. So it's going to be active external rewarming. And what do I mean? I want to be able to force warm substance, hair, fluid to that person's body, to deliver thermal energy actively by myself to the body. So you can do that by, still covering with one blanket, by using like warm water bath. So I am actively pouring warm water to the person's body. That's an active approach. But it's external because I'm pouring it to the body. I'm not sticking needle into the person. Or you can use forced warm hair blanket system. So all these ones to deliver like heat to the body. So warm water bath, force hair blanket system, use on warm blanket. Then when it's less than 20, so you need to go in. So I set line, I push in warm, normal saline, warm lingers lactate. So that is active, internal rewarming. So you want to consider that for people that have temperature less than 28. So setting line, pushing warm fluid through that through the line. Or you can even do like warm peritoneal and pleural lavage. So you make an incision through the peritoneum, the pleural cavity, you push fluid to the area. Or you can connect them to some machines like the ECMO. So the ECMO is very, very good, for rewarming too. So that's not very, very commonly talked about, but it is a possibility. So extracorporeal rewarming through the ECMO machine. And there's another complication of hypothermia that's called a frostbite. So frostbite just means when you start having like necrosis of like the extremities, the digits, the hands, the toes, the face, the nose, the hair, because somebody is exposed to too much cold. Cold is not the only cause, but the most common cause of frostbite is still going to be cold. So what happens is you have like freezing of the cellular spaces and the interstitial tissues of the body. They start getting frozen. So you notice that area is going to appear red initially. It's going to look red. Then later, there's going to be like it's going to start swelling up. It's going to start swelling up. There's going to be formation of blisters. Inflammation is going to start happening. There's going to be damage to the vessels, thrombosis of the vessels. So at the end of the day, the blisters will rupture and that area will appear gangrenous. So let me show us what like frostbite looks like. So frostbite. So the first thing is there's going to be like, we can see the blister form exactly. I like this picture. So let us look at the stage. So they start having freezing of that hand. They start freezing, right? So if you look at this part, it start freezing. And if you look at the first response we mentioned, erythema, so it's going to appear erythematous. Then later, because of the damage, there's going to be damage to the nerves. So the person is going to start having numbness in that area. Then the area will start getting swollen. We don't have the swelling phase here. They start appearing edematous with formation of blisters. So to get to this point, blisters from. Then later, these blisters will rupture, they'll burst. Inflammation is going to set in. There's going to be damage to the vessels with formation of thrombus. So when the thrombus now come in, the area is now going to cause like coagulative necrosis, and the hand is going to appear like this. So before it gets to this, within 24 hours, you might want to thrombolize. Don't be surprised if you go and pick thrombolysis in the answer for frostbite. Some people be confused. How? You want to prevent it from getting to this point because of the thrombus. So within 24 hours, you might want to, deliver your thrombolytic agent, break down the clot to prevent it from getting this. But the most common approach you want to do is to try to rewarm, and that's what we call the thawing. I don't know how to pronounce that word. I don't know. It's thaw. I think it's thaw. So you thaw, meaning that you are putting it in like warm water. I don't know. Please, am I correct? People that are familiar with the word, is it thawing? This word. Does anybody know the pronunciation? Okay, nobody's talking. So I think it's thawing or something. I don't know. So we put it in warm
So,
water. Okay, somebody wants to say something.
Yeah, we said yes, sir. You got it.
Okay, Toyin, so you put it warm water between 37 to 38 degrees Celsius. So, and you want to do that, and you want to give them analgesic because it's very painful. They can be screaming. By the time you dip the hand inside that stuff, it's going to be very, very excruciating. So you might want to give them like, narcotics to deal with the pain. And don't forget the temperature, like something like medium between 37 to 38. That's where you put the hand so that they can warm or reheat that area. Then if you have tried your rewarming and you are not seeing improvement, you might want to consider like thrombolizing, to break down the clots and preventing it from progressing to that. So sometimes you also want to connect all these people with hypothermia. You want to connect them to the ECG, to detect some arrhythmic changes because they can have bradycardia, they can have AFib, and they can also have a classic sign that we call the J wave, husband wave. It's not very important, but let's just see what is there. So J wave is the ECG finding of hypothermia. I doubt if they are going to be asking us J wave in our exam. There's a lot of important things, to show, but this is just a wave. So it's a sudden upward positive deflection after the QRS complex. So this is QRS complex here. Instead of it to progress and have the T wave, you're now having like another upward positive deflection, which you call like the J wave. So that's at the J point. So that's like Husband wave. Once you see this, that person is hypothermic. You want to check the temperature immediately. So, when it's very severe, you want to do the active internal rewarming, push in warm intravenous fluid. If there's any electrolyte derangement, particularly people with bonds, electrolyte derangement, people with adrenal insufficiency, electrolyte derangement. So you quickly want to correct the electrolyte derangement. If you're having like metabolic acidosis, your fluid is also going to help us with that, and the person is going to be fine. So we do not stop resuscitating until the patient has been rewarmed. You don't stop. Even sometimes the patient can even go like unconscious. We should not forget the 5 T's and the 5 what's it called? The 5 T's and the 5 H. So part of the H, hypothermia is there. So causes of like cardiac arrest and all those things, they can go into cardiac arrest. Particularly when it's getting to less than 28. So you might want to start your CPR immediately, connect your ECG, you see whatever reading is there, and you might also need to push in some antiarrhythmics to try to bring them back. So, and of course you want to also try to rewarm. So get the temperature back to like at least more than 32 so that you can bring them close to normalcy as soon as possible. Then they can come back to life. So usually you don't pronounce them dead because they could just be in cardiac arrest. So you continue to resuscitate them until you bring the body temperature to more than 32, unless the potassium is more than 12. So if somebody is having hypothermia, they are unconscious, you check potassium, it is more than 12. So most likely there's already irreversible cell death. So at that point, it's unlikely that they are going to come back. So most likely they are dead, So that is that. Then I don't think I have a question. Okay, I don't have any question. Yeah. So for hypothermia, this is opposite to hypothermia. So this one, and the potassium can also come, apart from cell death, could form from maybe muscle damage or from injury to the muscle and all those things. So let's have that too. So hypothermia is when you have the body temperature more than 40 degrees. So when it's more than 40 degrees, that is hypothermia. Unlike hypothermia, in which the body temperature is less than 35 degrees. So what are the causes of hypothermia? It could be from exposure to drugs, which can cause malignant hypothermia that we talked about yesterday. Some psychotic agents can cause NMS, which we'll have talked about in psychiatry. It could be from poisoning overdose. Maybe the person has taken some drugs, benzo, what's it called, and tricyclic antidepressant and all that things. It could be withdrawal syndrome from some drugs. They can cause hypothermia, or from environmental, particularly heat stroke. So people athletes like that do a lot of sporting activities in the hot sun, military people that march in the hot sun, they can develop heat stroke or heat exhaustion. So the difference between Heat stroke and heat exhaustion is just the presence or absence of neurologic symptoms. So if somebody is having hyperthermia, body temperature of 40, and the person is having neurologic symptoms, and you have ruled out all these malignant hyperthermia, NMS, and the likes, then you can say that this is likely to be heat stroke. So most of the time, heat stroke is going to be having involvement of multiple organ systems. So they can be having AKI, they can be having liver damage, they can get to the brain, and they are having like encephalopathy, they are seizing, they are confused, altered sensorium, irritability, all those things. You know that this is likely to be heat stroke. But if you have looked at the presentation, no drug related issue, you are seeing the temperature 40, and there is no CNS problem, you can say that, oh, this is likely to be heat exhaustion, not heat stroke. So the other causes include infections like sepsis, meningitis, tetanus, infection generally, cerebral malaria, endocrine, thyroid storm, all these things, a lot of what's it called, adrenergic activity, thyroid storm, pheochromocytoma, hypothermia. The neurologic problem too, when there's destabilization of the regulatory mechanism, the brain is the one coordinating the body temperature. So if it's disturbed, maybe from a lesion in the brain from like stroke, seizure, like somebody having status epilepticus, they are convulsing every now and then, continuously generating heat, there's going to be hypothermia. Or someone that had like cerebral vascular accident like stroke too, they can have hypothermia due to dysregulation of the homeostatic activity from the brain. So what do we do? You want to quickly bring that temperature down. Regarding etiology, you want to do like a rapid active cooling, rapid cooling of the body. So put them in. You can do like ice water immersion. Put them in ice water to bring it down quickly. And especially somebody with heat stroke, put them in that water to bring it down quickly. Cover them with wet blanket, cover them with ice packs to bring down the body temperature. If they are shivering, you don't want them to continue shivering, because if they continue shivering, it's bad, because they will continue to generate more heat. So give them benzo to calm the nerves and reduce the shivering. So that's the way to just approach it. Don't forget, it's just basic stuff. Cover them with wet blankets and ice water immersion, cold bath, and all those things that can bring down the temperature. So don't forget about NMS, malignant hyperthermia, the way we treat, serotonin syndrome, the way they present. I cannot start to be talking about all those things now, but I know we know it. We should just familiarize ourselves with all those things and get used to them. So I think I have a question here. Let's see. So this is a previously healthy 44-year-old man who is brought in by his co-workers because of, oh my god, sorry about this notification. Turn it off. I'm coming. So this is a previously healthy 44-year-old man who was brought in by his co-worker to the emergency department for 5 minutes after he became lightheaded and collapsed while walking in the boiler room of the boiler room of the factory. He did not lose consciousness. Good. His worker reports that 30 minutes prior to collapsing, he told them that he was nauseous and had a headache. He's lethargic. He's not oriented to time, place, or person. Temperature is 41. Pulse is 133. Respiration is 22. BP is 90. Examination shows equal and reactive pupil. Deep tendon reflexes 2+ bilaterally. His neck is supple. Infusion of 0.9% saline infusion is administered. A urinary catheter is inserted and dark brown urine is collected. Lab is as follows: it's hemoglobin of 15, leukocytes of 18,000, platelet of 51,000, sodium of 149, potassium 5.0, chloride 98, urea 42, glucose 88, creatinine 1.8, aspartate 210, alanine 250, creatinine kinase is 86K. Which of following is the most appropriate next step in the management? Anybody?
immersion.
Ice water immersion, very good. What's our diagnosis here and why?
Heat stroke.
Heat stroke, why?
There are some neurological findings
Neurologic
and
findings.
the
Yes, I agree with you. And of course, the temperature is hypothermic, 41. And what else? What else is supporting heat stroke here? What else?
the laboratory findings,
Okay, which one? Which one?
the elevated liver enzymes.
Elevated liver enzymes, elevated kidney stuff too. Urea is elevated. Creatine is elevated. So CK2 is very important. The muscle, 86K is a lot. So probably this guy's already having rhabdomyolysis. That's why he's not having like kidney issues too. So that's that. Okay. So moving on to bonds. So the bonds. So bonds, we don't need all this history. We just know that it can be chemical, it can be electrical, it can be thermal. So depending on what type, of inciting agent, you know what to do. So if it's chemical is going to cause changes in the pH. So we need to immediately do a copious irrigation of that part. So if it's chemical bond to the face, you need to copiously irrigate. That's the best next step. Even before you say that you want to rush to the hospital, you want to do something. That's not the time to be applying cream and applying oil. You want to irrigate with flowing water. That's what you want to do. To wash out the chemical to reduce the absorption. Then, if it's electrical is much more dangerous because in electrical bond, you might not even see like a physical damage in the body because the stuff is going to go into the body. So what happens is the electric current would get inside the body and to be converted to thermal energy. So it is the thermal energy that will now cause damage. And how does it cause damage? The first thing that will receive that electrical, stuff and get destroyed by the thermal energy is the muscle. They are the first. So it goes deep to the muscle and causes rhabdomyolysis. The vessels too are not spared. Now, but before we go to the vessel, the rhabdomyolysis is going to cause like damage to the muscle, and there's going to be elaboration of many electrolytes, particularly potassium. So damage to the muscle, there's going to be inflammatory response, a lot of blood flow to that area, leading to compartment syndrome. So one thing that should always come to our mind with respect to electrical injury is that, okay, this muscle is going to suffer, number one. Inflammation is going to happen there, number two. Fluid is going to be there, number three, and there's going to be enlargement of that compartment, causing acute compartment syndrome. They tell us that somebody has immediately lost pulses, after having like electrical burn injury. You want to go and do what? An urgent fasciotomy, because you know that's likely to be compartment syndrome. Having pain, reduced pulse, paresthesia, compartment syndrome. Some people will be finding it confusing that what's the link between compartment syndrome and I cannot go and be picking fasciotomy now. So that is the link that we have explained. So, and because of the rhabdomyolysis, it can explain the electrolyte abnormality that we have said, which is hyperkalemia, hyperphosphatemia. Everything will be released from the muscles. All those electrolytes will be released from the muscles. And of course, some of them can trigger arrhythmia, particularly potassium. Once it's more than 6.5 or something, and you have not given calcium gluconate, that is arrhythmia that person is joking with too. So, then after the muscle, it goes to the vessels, destroy the endothelial lining of the vessels, cause thrombosis of the vessels, and it will reduce blood flow to the downstream organs. So you always want to be monitoring the pulses from time to time because you are scared of thrombosis of the vessels with eventual ischemia. So some people will just suffer ordinary electrical burn and they can end up losing their legs or their hands. Why? Because of thrombosis to the blood vessels. So everything that we have in this area, we have explained it. So they suffer muscle damage. There's going to be electrolyte problems. So monitor potassium, obtain an ECG. They can have compartment syndrome, which can affect the pulses. They can have thrombosis of blood vessels, which can affect the pulses. Because of the compartment syndrome, you want to quickly do like debridement and fasciotomy to prevent it. Very, very important. If the thrombosis has occurred and there's no active intervention immediately, the person can end up having the gangrene of that extremity, and there might be a need to consider amputation. Very simple. Electrocapoid. So, so for the last one, that's the thermal bond. So thermal bond 2 is much more like normal one. Most of the time for thermal bond, you are going to see like that break in the skin, So we are going to talk about the way you manage that. So the one that just have some special consideration, that's the one that we have talked about now. Yeah. So looking at the depth of bond wounds, especially from thermal bond or chemical. So what's the depth? So the way we should classify it ideally should be like superficial, thickness. Then we have the partial thickness, which can be considered to be superficial or deep. Then we now have the full thickness and the 4th degree. So that's the way it should be. So, okay, thank God we have it here. I like this. So this is it. So superficial thickness. The only area that is lost in superficial thickness is the epidermis. It is only the epidermis. Now, you just see redness. Because what is happening here is just histamine. Like histamine, like vasodilation kind of presentation. Redness, that is all. No break in the skin. It's only the epidermis that is taken out. So it's still like, you won't see anything. You just see like erythematous area. Then, for the 2nd degree, we have 2 types. We have like, so no, let me just follow what is here. So 2nd degree, we have superficial partial thickness. So now, one thing I want to say is that in superficial partial thickness and superficial thickness, the pain sensation is intact. So once you have mentioned the word superficial, pain sensation is intact because it has not gotten to the part that it has affected the pain fibers. So superficial is mentioned, there's going to be pain sensation to be intact. But once you mention the word partial, that means that there's going to be formation of blisters. So once they tell you that somebody has blisters in the skin and it's painful from burn, I automatically know that is superficial partial, because superficial there's pain, partial there's blister. It's as simple as that. And the level for somebody to have superficial partial thickness is that the burn injury has gotten to the papillary dermis. It has gotten beyond the epidermis through the papillary dermis. So when the burn injury extends to the reticular dermis, so that is going to be a deep partial thickness burn. Now don't forget, there's still the word partial there. So they are going to tell us that the person is having blisters. But it's deep, not superficial, so there's no pain. Pain is gone. So this person is not going to feel pain, but we are going to be seeing blisters. So we can say that this is a deep partial thickness burn injury, right? So for the full thickness one, it has gotten beyond the reticular dermis. It has gotten like to the subcute. So that is a full thickness burn injury. So that kind of person is not going to be having blisters. So they will tell you that the skin appears charred, appears thickened, appears leathery, white, waxy. Just know that is full thickness that they are telling us. No, nothing like blister. Blister is gone, and there's not going to be any pain. So, and sometimes you can even get down to the bone, to the muscle, and the like. So that's the classification. Do we understand the classification, or you want me to go over? Anybody? Is this something we can say again? Do we get it?
Please go over it one more time, please.
So if we say that someone is having like a superficial, burn injury, superficial, so that means that it is only the epidermis that's taken off. So that area is going to appear red, that's all, and there's going to be pain. If you say someone is having a superficial partial thickness burn, it has gotten to the reticular, to the papillary dermis. Because of the word superficial, just like the first one we have said, there's going to be pain. But because we are now saying superficial partial, so this partial means there's going to be formation of blisters. So superficial partial thickness burn, pain is intact, and there's going to be blisters. So if you say deep partial thickness, because it's now deep, no pain again. The pain fibers will have been taken out, so no pain again. But partial is there, so there's going to be blisters. So somebody having blisters with no pain, that's a deep partial thickness burn. So if there's no blister and there's no pain, and what we are just seeing is leathery, waxy, charred skin, that's a full thickness burn. Sometimes you see it extend to the bone, the muscle, the subcutaneous layer, and the like. Do you understand that? Does that algorithm work for us?
Yes, sir. Thank you.
So, what are the organisms that we expect? Burn injury, rule out Pseudomonas, especially, and MRSA. So, Pseudomonas is the most common one that you have to worry about. Complicate burn injury, Pseudomonas. And if you don't see Pseudomonas in the option, pick MRSA. So, sometimes they might get, you look for the skin wound, sometimes they might have like deep destruction not visible to the skin, in the skin. So I said that for electrical burns, you won't see any outside external injury. Sometimes they can get burns and they will have inhaled some smoke, so they can have like carbon monoxide poisoning, and due to burning of plastics, textiles, carpet, they can have cyanide poisoning, which we are going to talk about shortly too. So people with burn injury, you want to manage them, ATLS protocol, ABCD, that's it. Check the airway. Is it clear? Any singe hair in the airway, any like obstruction, anything occluding in the airway, if there's an occlusion, remove it. Check the breathing. Can they even talk? Are they breathing fine? The chest movement, all those things. Then C for the circulation. You want to push fluid immediately, and the like. So ABCD criteria, if you see that the airway is compromised, you might want to quickly intubate there. Don't forget it. So how do we calculate the surface area of the bone so that we know the amount of fluid we are going to deliver when we get to the stage C? So the way to just look at it is just the only one that have smaller number is the head and the upper limbs. Other ones, you give it 9. Head and upper limb, you give them 4.5 each. So rule of 9. Front of the head, 4.5. The back of the head, 4.5. The front of the upper limb, 4.5. The back of the upper limb, 4.5. You now divide the body part, this part here, into the chest and the abdomen. So the front of the chest 9, the abdomen 9, then same thing, the back of the chest 9, the back of the abdomen 9. Then they give the perineum 1, and the front of the lower limbs, entire lower limbs 9. The front of the second entire lower limbs 9. The back of the entire lower limb 9. So the only part that is taking 4.5 is the front of the head, the back of the head, the front of the upper limb, the back of the upper limb. So if somebody comes to us and the person is having burn injury here, just here, that is 4.5%. Burn injury affecting the head only, 4.5%. Affecting the chest only, 9%. The back, 9%. So if it's affecting both back of the chest, back of the abdomen, 18%. So we have to have this at the back of our mind. Now, so people that are exposed to smoke from the burn injury, maybe they're in a building, sudden fire, smoke everywhere, they can have inhalational injury, carbon monoxide poisoning, cyanide poisoning. We're going to talk about this. So you might want to obtain a chest x-ray, do your carbox hemoglobin level, and acetate. So you should also access for circumferential eschar formation. Why? Because some of them can have some burns that is circumferential. So it means that you just have burn injury, like in this part like this. So what will happen is if they have burn injury like this, it's going to cause the skin elasticity to be lost. So the skin is not going to be elastic again. It's going to be constricted. So that constriction is going to impair blood circulation to that area. That area is now going to become necrotic. So, and you call that formation of eschar. So that necrotic tight area can impair blood flow to the surrounding structures, which is bad. So you start noticing that the pulse in that area, if it's happening in the hand, the pulse here will start dropping because of this circumferential constricting burn injury. So once there's a circumferential injury, loss of skin elasticity, that area becomes constricting, impairing blood flow to the downstream structure. And of course, because of the constriction, the elasticity that is lost, that area is going to become necrotic. So you have to go and remove that eschar tissue that's causing the constriction. So that's what we call escharotomy. It's different from fasciotomy. You do fasciotomy for compartment syndrome. You do escharotomy for circumferential bone injury. So, so that is that. Just tell us that somebody is having splinting. They cannot breathe after burn. It's likely that there's an hair scar somewhere there that's impairing like ventilation. So we want to look at their body, expose it very well. Notice that there's part of the body that is having like problem with the pulses. Think about circumferential bone injury too, and you want to quickly go and do a escharotomy to remove the necrotic tissue that is constricting on that skin. So, they can obstruct both the venous and the lymphatic drainage, leading to vascular compromise and compartment syndrome. Very important. So how do you treat bone injury? ABCD. You've done your airway, you check for the breathing. Now it's time to give fluid. So how do you know the fluid to give? So use the Parkland formula. 4 ml per kg per body surface area. So this person is 20 kg. 4 ml times 20 times. What's the body surface area of the bone injury? Oh, the bone injury is just affecting only the head. So that's 4.5%. So just come here and put 4.5% as the surface area. 4.5%. And we multiply. So this is it. 4 times patient weight times the percentage PSA. Then whatever we get, maybe we get 100. So we are going to divide that 100 into 2. 50-50. We give the first 50 in the first 8 hours. Then we give the remaining over 16 hours. So that's the way we apply Parkland formula in, giving fluid during bone injury. Then, of course, because the skin is denuded, there's break in the skin, you might want to give some antimicrobial so that you don't allow Pseudomonas and all those things to enter. But that is not the time to be giving anti-Pseudomonal agents. So what they use is mafenide or silver sulfadazine. Don't never go and pick ceftriaxone. You are going to be wrong. So prophylactic antimicrobials, especially if somebody have superficial partial thickness and beyond, when there's damage to the epidermis. So you might want to give mafenide or silver, sulfadazine. So no proven benefit when you give oral or IV antibiotic or steroid. So just go and give mafenide or sulfadazine. We have talked about sclerotomy to relieve obstructed vascular flow in circumferential bone. Don't forget this. Very, very high use. So because of the injury, consider giving them tetanus vaccination. Because of the fact that people with burn, they have a lot of fluid loss. So there's a compromise to blood flow in the GIT mucosa. So because of the reduction of blood flow to the GIT mucosa, they can have ulcers in that area. And you call that the stress ulcers. So it's just the same principle as giving ulcer prophylaxis in someone that's having GIT bleeding. Somebody comes with hematemesis from portal hypertension and they are bleeding madly. I will give them stress ulcer prophylaxis. It is because of compromise to blood flow to the GI mucosa. The same thing occurs in bone injury. Give them PPI or proton pump inhibitor because you don't want to make them develop stress ulcer, injury. Then because of the pain, give them IV necrotic. Bone injury is very painful, very, very painful stuff. So I've never had one before, but I can because of course we touch bone hot stuff, so you know what they are going through. So give them IV narcotic analgesics. Right. So that is all about bone injury, and let's see if we have any question here. So there's a question here, and yeah. So this is a 32-year-old woman who is brought to the emergency department for evaluation of bone injury that she sustained after stumbling into a bonfire 1 hour ago. The patient has severe pain in her left leg and torso and minimal pain in her right arm. She does not smoke cigarettes. She takes no meds. She's tearful and moderate distress. Temperature is 37.2. Pulse is 88. Respiration is 19. BP is 118. Pulse oximetry is 98. Cardiopulmonary examination shows no abnormality. There are 2 tender, blanchable erythema without blisters. What bond is this? First degree, second degree, third degree, fourth degree, fifth degree. Which one is that?
First degree.
First degree. Thank you. Over a 5 by something, blah, blah. In the left abdomen and in the 3 by 2 in the left anterior thigh. Okay. There's also an area of white leathery skin and tissue necrosis encircling the right upper extremity, just proximal to the elbow. What kind of bone stuff is that?
Fourth.
Yeah, so it's fault, yes, I agree. But what is that specifically describing?
Circumferential.
Circumferential. So what is this guy going to benefit from that?
Escarotomy.
So ECG shows blah, blah, blah. Admission of IV fluids. Which of one is the most appropriate next step in the management? So let us read the option. Serial arterial blood analysis, soft tissue ultrasound, intravenous ampicillin. We will have strike this one out, true or false?
True.
We will have strike it out. So monitoring of peripheral pulses and capillary feeling, X-ray of the chest. Anybody? What are we picking?
ABC.
What did we say?
Monitoring of peripheral pulses.
Monitoring of the peripheral pulses. Why? My people.
But what? Because of the experience of escarotomy.
Because of exactly, this guy is having circumferential bone. Don't forget, there's going to be increased tendency, of vascular compromise because of the eschar that is there. So you have to monitor the peripheral pulses and the capillary feeling. Don't forget, it is just proximal to the elbow. That hand can go at any time. So immediately you want to go and schedule this guy for escarotomy, and you want to monitor the peripheral pulses from this. So this one has no role. I think somebody picked A. Arterial blood analysis, no. When somebody is having escarotomy, so this one is much more urgent, than this. So 3 hours later, patient is reassessed. Right arm is put in elevated position and physical examination of the extremity is performed. The examination reveals reduced capillary return and peripheral pallor. The pulse of 84. Which of one is the most appropriate next step? What are we going to do?
You're supposed to do it.
This is not fashion. This is not compartment. Because they told us that this guy is having it's escarotomy. So I think you have to go and amputate. I think so. So the patient is reassessed. The right arm is put in elevated position and physical examination of the extremity is performed. Examination now reveals reduced capillary return and peripheral pallor. So the hand is now pale, and his pulse examination shows oxygen saturation of 84. No, I think it's fasciotomy that we do. Don't worry, I'll check that question to be sure, and I'll get back to us. I don't think we can amputate it just like that because it's not showing evidence of gangrene. If there's gangrene there, then we can go for amputation. I think it's fasciotomy that will be the best thing here. That because people with these eschars too, they can, in a way, develop some form of compartment, syndrome too. So just like we have here, because it was stated here, they can develop compartment syndrome. But that question is not actually well set. If you look at it, it was mentioned that they can have. I'm coming. They can have. To just prophylactic fasciotomy and debridement to prevent compartment syndrome. It could be, part of what they can have. So, but the best answer there should have been escarotomy. It should have been escarotomy. So, fasciotomy would be the best. So that's why when we get to our exam, we have to open our minds and look for the answer that is best fit. Sometimes you might not get something that you are sure that this should be what, but just trust your gut that, okay, from what I'm seeing here, this should be the most appropriate. You find yourself in that kind of situation many times. I'm not cursing, maybe some couple of times, but we just have to go, with our gut that, this should be the most likely answer in this situation. So the best answer should have been escharotomy. If we see escharotomy in this option, pick that one first. But this could also be like feature of compartment syndrome, because you can see like there's pallor, there's pulselessness, kind of, OSAT is dropping. They didn't talk about pain though. So, but fasciotomy will be the best. You can't just go and jump to what's it called, amputation like that, unless it's gangrene. That's when you want to amputate. Okay, so a 44-year-old man is brought to the emergency department by a co-worker 2 hours after accidentally burning his foot on an electric grill that he keeps, next to his bed because he likes to wake up to the smell of bacon. He initially decided to go to work despite his injury, but felt like it was too serious to ignore. He's the regional management of the patient of the paper company. His vital signs are normally limit. Examination of the right foot shows erythematous skin with multiple blisters, some which have ruptured. The affected skin is tender to touch. Which of the following best describe this patient's skin findings? So what kind of grade is this? I like this question. What kind of grade is this? Anybody?
Second degree
Second degree.
partial thickness.
Superficial partial.
Superficial partial.
Exactly. Superficial partial. Why? Superficial because there is what?
This
Still
is
having pain.
No,
Pain.
no,
So the
pain.
pain is still there. So pain because partial because there's still what? Blisters. So I know it can be confusing, but just entertain. Don't say PEEP and PO. So P is for blister, S is for the pain. So official means it's still high up. The pain fibers are not still have not been taken out, so they will still feel like touch and pain. Then partial means there's going to be blisters. So once you see that, you'll be able to know what kind of. Oh my God! See, my people, do you see what happened? Anybody see what happened?
The last option should have been from the other question.
God bless you. You see, that's how you know that you know what you are talking about. That is it. I made a mistake. So the answer here is escharotomy. And I was thinking about it that it's possible that I did not cut out that option well. So they'll put fasciotomy there, confuse us. So the answer is going to be that's the best. If you see both of them together, pick escharotomy. So the answer is escharotomy. Thank God for that. Okay. Yeah. All right. So so moving on to drowning. Right. So drowning. So somebody just drown, they get immersed in water. They can have aspiration, they take in a lot of water, can get to the lungs. So we should access for hypotension, hypothermia. So the thing is, once they come in first, you still follow the ATLS, ABCD. Look at the airway, look at the airway, look at the breathing, look at the circulation. So sometimes you might need to immobilize the neck with a cervical collar, especially if you get history that they got drowned in a shallow water. If the history tells you that the drowning occurs in shallow water, suspect neck injury. Don't suspect, assume neck injury and put in a C-spine. Because they have a high tendency of hitting their head to the. But if it's like a large pool that's very deep, it's not likely. So don't go and be ordering cervical spine in that situation. So just do normal ABCD. Look at the airway. If the airway is compromised, they are already having alter sensorium, cannot maintain that airway, go and intubate immediately. Check the breathing. If there's a need for oxygen, give it. Check the circulation, pulses, blood pressure. If you need to give him fluid, give him fluid. So most of the time, the cause of the hypotension is due to myocardial depression from the hypoxia. We know that if somebody gets drowned, there's going to be like initial respiratory effort that's going to be increased. They want to gasp. It will look as if the earth wants to end on them. It has happened to me before. It's not that I almost drowned, but like I could perceive that feeling that I'm going inside the water. You should, you look. I don't know how to describe that feeling, but I'm sure that some of us know what I'm saying. So you quickly want to breathe out for air and breathe. So that initial hyperventilation, can happen in them. So in the in the event of trying to take in a lot of air, reach out for air, they can aspirate. So when they aspirate a lot of water, gets to the lungs, hypoxia sets in. When they do the vital organs like the brain, the heart do not get oxygen for a long time, they start failing. So because of myocardial depression, they start having hypotension. So that's the cause of hypotension there. And of course, because they are in cold water, they're hypothermic. And because of the aspiration, the lungs is congested with a lot of fluid. They're having non-cardiogenic pulmonary edema. They can have hypoxemia. Very simple. Very, very simple. So you will have done your primary and secondary survey by the time they come in. A, B, C, D, E. A, airway. B, breathing. C, circulation. D, look at them. Look at their body. Check glucose. Neurologic examination there. E, exposure. Remove all the wet fluid from their body. Take it out. Look at all their body. Any obvious injury. Then you now do like secondary survey, which is now going to be like proper systemic examination. Look at the chest. Normal, S1, S2, normal. Please say that one. Look at the abdomen. Look at the musculoskeletal. Look at the brain and all those things. Don't mind me, I'm just joking. So then we order the chest X-ray to see if there's any fluid in the lung. We can see the pulmonary edema. Then CBC, just to see if there's any derangement of the blood count. Most situation is going to be normal. Then of course the ABG to see, the oxygenation parameters. Then how do we treat them? Just remove the wet clothes, rewarm them. So depending on the temperature, if it's less than 35, you want to do like passive external rewarming, like between 35 to 32, passive external rewarming. Cover them with blanket, remove the wet clothes. If it's between 32 to 28, that's going to be active external rewarming. So first hair, blanket, we can, like deliver like warm hair to the body, cover them with warm blankets and all those things. Then if it's less than 28, you want to do what? Deliver warm IV fluid to the body. You want to do like peritoneal pleural lavage in the extreme cases and connect them to ECMO if it's available. So, but don't forget, sometimes you might need to intubate, particularly for people that have water sensorium. They cannot control their airway again. They are very, very drowsy and confused. Intubate them. So, but if the child comes in, the person is normal, no problem. You want to observe them for 8 hours. Do a chest X-ray, observe them in the hospital for 8 hours. Don't pick discharge home. Observe for 8 hours. Then if you can order the X-ray again, so if it's normal, tell them to go home. So that's the way we manage drowning. Then for altitude sickness, do I have a question here? Okay, I do. So this is a 3-year-old girl who is brought to the emergency department 20 minutes after she was found face down in a pool by her older sister, by her older brother. The siblings were playing outside the garden of their grandparents, and the brother reports that he went inside to get something to drink and discovered the sister floating in the pool when he returned. The grandfather took her out of the pool and called an ambulance. On arrival, the paramedics found that the girl was somnolent but spontaneously breathing. En route to the hospital, they initiated bag max ventilation to 100% oxygen. She remains lethargic. Her temperature is 34.2, pulse is 80, respiration is 34, and blood pressure is 90/60. Pulse oximetry on 100% oxygen administered via a non-respiratory mask show oxygen saturation of 88. There is no evidence of trauma to the head or the neck. The lips appear bluish. Pupils are equal and reactive to light. The airway is clear. Pulmonary auscultation shows diffuse crackles and wheezing. Femoral pulses are palpable bilaterally. Reminder of the examination shows no abnormality. Which of following is the most appropriate initial step in the management?
Intubation.
No. Cover in,
Intubation.
Cover in one blanket.
cover in one blanket and observe for at least hours.
Passive
Why?
external.
Okay, let's have a look at this question again. On arrival, the paramedics found that the girl was somnolent but spontaneously breathing. Okay. En route to the examination, they initiated bag mask ventilation with 100% oxygen. She appears lethargic. temperature is still 34.2. These are the person is still hemodynamically unstable, and the pulse oximetry is 100%. We are not showing 88. There's no evidence of trauma to the head and neck. The lips appear bluish. Pupils are this. Airway is clear. There's wheezing and crackling. Please, my people, what are we to do for this patient?
Intubation.
Intubate this patient. This guy is having cyanosis. Even with oxygen, 100%. Saturation is 88. Hemodynamic compromise, 90-60. We can never cover with one bladder and observe. No, this one is going to die. So we need to quickly, perform endotracheal intubation. Then we now push in what? What do we now do? Anybody? What's going to be the next thing to do after we've intubated? Anybody? What are we going to do for this patient? Anybody? What can we do?
Surfactant. Wow.
No, not surfactant. Well, you can consider surfactant, but I don't think surfactant is like next, because look at the blood pressure. So I think out of this option, the best thing we can do here is to what? Administer intravenous warm cloth, so that you can use that one. You can use one stone to kill two birds. Use that one to bring up the blood pressure, and also to correct the, hypothermia. Even though it's not within the level of less than 20, yeah, I get it. But this guy is already having hemodynamic compromise here, so you can consider doing this. It can help. Then of course, intubation should be the priority. Very, very important. So if the child is normal, not cyanotic, they tell us that the child is playing around in the garden, in the hospital premises. So we just say, okay, you can cover with one blanket and observe for 8 hours. So but if somebody is cyanotic, we can never rely on one blanket and be observing. So we have to do something active. Okay. So high altitude sickness. So these occur in people that ascend very fast to a very high altitude. So like more than 20,000 feet, or more than like 2,000 to 2,005 meters. So if somebody moves like 2,000 to 2,005 meters, 2,005 meters, or like 20,000 feet, very fast, they can develop high altitude sickness. And what happens? So it is a clinical diagnosis, and I have the changes that happens here. So when somebody ascends, don't forget that the FiO2 or the PiO2 decreases with, as people ascend through the altitude. So the oxygen concentration decreases. So there's going to be hypoxia, which is going to trigger ventilation to get in more air. So there's going to be tachypnea. But in the process of hyperventilating, you are taking out CO2. So there's going to be a respiratory acidosis, so alkalosis. So that's where the problem will now start. Now, in response to that respiratory alkalosis, and also in response to the hypoxia, there's going to be increased glycolysis. And don't forget, one of the byproducts of glycolysis is what? From biochemistry, 2,3-BPG. And this always shifts oxygen dissociation curve to what? To the right. So that the hemoglobin is going to be offloading oxygen to the tissues for their use, so that they can have increased tissue oxygenation. So this is what happens. This is the adaptation to high altitude. Now, don't forget, if you do not come down, this thing cannot sustain the person for a long time. So it means that the person is going to be having a chronic respiratory alkalosis, and a lot of alkali in the body is bad for the brain. So what happens? They are going to have acute mountain sickness. So acute mountain sickness. So they start having dizziness, headache, vomiting, nausea, fatigue. So once they tell us that somebody ascends to the mountain, within 12 hours, the person is already having dizziness, headache, nausea, vomiting, automatically, that is acute mountain sickness. Now, they can have a progression of the complication, and they can develop high altitude pulmonary edema that I call HAPE. 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 So now, what happens in HAPE is that we remember that there's hypoxia because they are going up. And we remember that the the response of the pulmonary vasculature to hypoxia is what? How does it respond? Anybody? How does it respond?
Vasoconstriction.
So there's going to be
Constriction.
vasoconstriction. So it means that the pressure within the pulmonary vessel is going to be high. So that hydrostatic pressure is going to be high. That is going to be forcing fluid through the endothelium into the lungs. So they are going to have a pulmonary hypertension, forcing fluid into the lungs. So that's the cause of their pulmonary edema. So they can have cough, shortness of breath, hypoxia, and crackles especially. You hear crackles or rails. You know that, oh, this guy is already developing ape. Now, the third is ACE, which is HACE, the high altitude cerebral edema. And now, what happens here? There's hypoxia, but the cerebral vessels will never undergo vasoconstriction. They will rather vasodilate in response to that hypoxia, so that more blood can rush to the brain. But it becomes too much that it even overpowers the autoregulatory mechanism of the brain. So the blood becomes too much, and hydrostatic pressure builds up, and at the end of the day, blood is going to move into the brain tissues, causing cerebral edema. Very important. Now, what do you see? They start telling you that the person is already become drowsy, confused, having seizures, and ataxia. Ataxia is a very prominent sign. Cannot steady his gait again. Having confused gait. This guy's already having high altitude cerebral edema. Now, what do you do? The best next step, all these things, the best next step is to descend. Calm down. Calm down. Before you even start talking about anything, calm down first. Why are you going up? Calm down first. That's the number one thing you have to pick in your option. Descend immediately. Then you now consider giving supplemental oxygen to even take care of the initial problem. Give supplemental oxygen. Now, what is common to all of them usually is headache. So you have to give like analgesia, like NSAID for the headache. So you can give them acetazolamide, especially people with Monte sickness and people with high altitude pulmonary, no, people with Monte sickness and people with high altitude cerebral edema. You can give them acetazolamide. And the idea, behind giving acetazolamide is that if you remember the way acetazolamide work, what's the mechanism of action of acetazolamide? Anybody? It is a
Carbonic anhydrase inhibitor.
carbonic anhydrase inhibitor. So which is the enzyme that converts what's it called? CO2 and water to give bicarbonate. So that means that if I inhibit that enzyme, I can no longer form bicarbonate, which is an alkali. So no more bicarbonate again. And don't forget, one of the problems in them is that they have respiratory what? Alkalosis, which is causing the problem. So a lot of alkali. So why not me just stop the production of the alkali? So that means there's low. They will drop the bicarbonate so that they can induce what? Metabolic acidosis. So that to take care of the respiratory alkalosis. So that's the idea behind giving, acetazolamide. Some of them can even pre-medicate with acetazolamide so that the respiratory alkalosis does not cause problem for them. As respiratory alkalosis is happening because they're hyperventilating, they're already having like some form of, metabolic acidosis to counter it. So it does not even happen. It just equalizes. So they can pre-medicate with acetazolamide. Now, some people can take Dexa, and the idea behind taking Dexa is very, very important for high altitude cerebral edema because you want to stabilize the blood-brain barrier, you want to limit the vasodilation, you want to reduce the inflammation there so that they are not going to be having, cerebral edema. So Dexa is very good for HACE. Another drug that we should not forget is nifedipine or sildenafil. And this one is very good for people with APE. Because don't forget, the problem in APE is that the vessels are responding to the hypoxia by undergoing vasoconstriction. We don't want that vasoconstriction to happen. So I'm going to vasodilate that lung. I'm going to vasodilate the vessels. So it makes sense for me to give nifedipine, which is a vasodilator, or sildenafil. So that I can prevent pulmonary hypertension from happening. So once you understand the pathophysiology, you'll be able to correlate, the treatment you are going to be giving them. Okay, this one will benefit from this one will benefit from that. Then, of course, you always encourage them to come down, descend from there. So that's that about IgG signal. Very simple, very straightforward. So, microbiology of bite. So, Pasteurella is one thing you must always consider. People that bite people, they are inoculating Pasteurella. You get Pasteurella usually from dogs, from cats, Patonella, and also Staph aureus and Strep from human bites too, or Ekingella. All those ones are very common in human bites. So, if somebody sustained a bite injury, do not close that wound. Do not close. Let it heal by, its secondary intention. What do you call it? Open it, heal by itself. Then you immediately administer amoxicillin. Don't ever forget this. Administer amoxicillin. So, how do we manage bite and sting injury? So now, if somebody suffers bite and sting injury, you need to give rabies, especially if there's a bite from like a cat, a dog, or a wild animal. You need to consider rabies. Now, regardless of your rabies vaccination, you must get something. It's just like a baby that is born to HIV mother. Regardless of the count, the baby will get something. Either the baby will get Zidovudin alone, or the baby will get New Zealand. The baby will shall get something. So the same thing applies to rabies. You get bitten by a wild animal that we cannot euthanize, or you get bitten by a dog that is rabid. Regardless of the previous vaccination that person had, the person is going to get something, unless that dog or the animal is vaccinated. So let us look at the algorithm. So we look at the one on top. Somebody gets bitten by a domestic dog or a cat. The best next step is to ask the owner, please, is your dog vaccinated against rabies or not? We know the white people, they trust themselves, so they can rely on the information that the owner is giving us. So if the person says that, my dog is LDO, it has been vaccinated, you don't need to do anything to that person. You tell the person, okay, you are safe, you can go. But if the vaccination of the dog is unknown, or the dog is not vaccinated at all, then what we do, the best step is to quarantine that dog for 10 days. So we isolate and put that dog in a place and watch it for 10 days. If that dog is rabid, within 10 days, the dog will have started showing signs and symptoms of rabies. So we know. So if within that 10 days, the dog is now showing signs of, rabies, then we now give prophylaxis. So this algorithm is wrong at this point. So this should be prophylaxis is needed. It should be no prophylaxis. So there's like a mistake, So signs of rabies, give prophylaxis. If there's no sign, you don't need to give any prophylaxis. Now, let me stop there. Let's now go to the other one. So if the person is bitten by a wild animal like a bat, skunk, raccoon, so we need to know the animals that are actually that have a high risk of carrying rabies. So the bat, the skunk, and the raccoons. So what you do is that you want to euthanize the animal. You want to, capture the animal and kill it, and go and subject the brain specimen to analysis and check if there's rabies there. So you euthanize and you check the brain for the negri bodies for rabies. So if the animal is negative for rabies, you don't need to give prophylaxis. But if you euthanize the animal and there's rabies there, you need to give prophylaxis. You also need to consider for prophylaxis if you cannot get the animal. So if the animal disappeared, you now say, guy, come, you go get rabies because you cannot see this animal to euthanize. You have to get the rabies. Now, what we are now going to be administering as prophylaxis depends on the vaccination status of that individual. So if the person has not been vaccinated before, so it means that the person is going to be getting both the vaccine and the immunoglobulin. So because if the person is not vaccinated before, there's no immunoglobulin in the person's blood. So you need to supply immediate immunoglobulin to neutralize the toxins and also vaccinate to protect from future, exposure. Then if the person has been previously immunized, you know that recent interaction with the animal, they are still kind of safe a little. It's not going to be very bad. So just administer the vaccine alone. You don't need to give immunoglobulin. So previously immunized, just give vaccine alone. Not immunized at all, give the vaccine, which is like active immunization, and also your passive immunization, which is the immunoglobulin together. Do we understand this algorithm? I think it's clear. Is it clear to us?
Yes.
Okay, moving on. Then I'll check back. So then we also want to consider for the need for tetanus. So for tetanus 1, the first thing you need to do is to look at the wound. What is this wound? Is this wound a clean wound or a dirty wound? So somebody that undergoes surgery now, that's going to be a dirty wound. Somebody that has a puncture with a needle stick, a sharp like knife, razor, those ones is going to be like dirty wound. Somebody wants to go and play football and there's injury, dirty wound. So clean wound is just going to be like abrasion and all those things. So minor wounds, clean wounds, they are, you know, like abrasion, laceration, and all those things that is not contaminated with any dirt or any object. So if somebody has laceration that has been contaminated with sand, it is a dirty wound. So now you classify like that. Is it clean or dirty? Because it's going to affect your approach. Now, if I figure out it's clean, so the next thing you want to ask the person, have you even taken the 3 lifetime toxoid dose before? Oh, yes, I've taken it. Okay, you are good. No prophylaxis. Oh, yes, I've taken the 3 lifetime donation. But so when did you take your last toxoid? The last toxoid I took was 11 years ago. That is more than 10 years ago. So we need to give this person the Tdap vaccine. So either the person has not completed 3 lifetime toxoid, or even if the person have completed that, but the last toxoid was more than 10 years, more than 10 years, you have to give the Tdap vaccine. But if this 2 criteria is met and the person is okay, just leave the person. But for dirty wound, 2 things. You want to look at them separately. 3 lifetime toxoid, 5 years for the last booster. So if the person has not collected 3 lifetime toxoid, so you are going to give both the vaccine and the immunoglobulin, because immunoglobulin has not been established in that person at all. If you have not gotten 3 lifetime toxoid, you cannot have adequate immunoglobulin in you. So you need to give them both the vaccine and the immunoglobulin. But if the problem in that person is that the last time they took the toxoid was more than 5 years, not 10 years now, more than 5, because you have a lower threshold for, what's it called? Your threshold is very, very much higher, rather, in the sense of it, for dirty wound. So your threshold is 5 years. So if the last time they took the last booster dose was more than 5 years, so you have to consider them for the vaccine again. You must take that booster, take the vaccine again. So you give them the TD vaccine. But if they meet the 2 things, they have taken the 3 lifetime toxoid, and the last time they took the last booster toxoid was less than 5 years, then you don't need to give them any prophylaxis. So remember the rule of 5 for dirty wound. So you are looking at 3 years. Is it completed? Have you taken 3 years booster? The 3 times booster, rather, the 3 times booster. 3 times booster. Yes, okay. Now, when was the last time you took? No. Have you taken the 3 times toxoid? Yes, okay. But when was the last time you took your booster? Oh, the last time I took my booster was 6 years. Oh, so that means that, well, immunoglobulin is there, but I still need to give you the vaccine. You ask the person, dirty wound, have you taken your 3 lifetime toxoid? No. You don't even have immunoglobulin. You need to take both the vaccine and the immunoglobulin. If it's clean, you ask, have you taken your 3 lifetime toxoid? Yes, you are fine. But when was the last time you took your booster? The last time I took my booster was 11 years or 12 years. Oh, you need to take Tdap or TD. Have you taken your 3 lifetime toxoid? No. You need to take TD or your Tdap. So you don't give immunoglobulin for clean. You don't. Because there's nothing to protect against immediately. Because it's clean. That's just the idea. So, do you understand the algorithm? Is it clear to us?
Yeah, please let me
Yeah.
ask. What is a toxoid? Toxoid, is it a vaccine or a booster?
So toxoid is a type of vaccine. What you are giving is a toxoid vaccine, meaning that you are taking the toxin. So so there's a way the scientists will obtain the toxoid. They obtain the toxin of diphtheria. You know that diphtheria has toxin, Clostridium have toxin, Clostridium tetani, they have toxin. They will take it. They are not going to inactivate that toxin, but its immunogenicity is not lost. So once they inject that toxin into somebody, there's going to be immune response. So if you take the toxin that has been inactivated, you call that toxoid, and you now put it in somebody so that they can produce immunoglobulin, that is a toxoid. Do we understand that?
Yeah.
So that is different from tuberculosis, because we don't know tuberculosis toxin. We take that organism itself, not the toxin. It is the organism itself that we are putting in BCG. You know, it is the organism itself we are using in all these what's it called? Which example can I give again? You know, all these hepatitis B, you know, the agent is what we are putting, the virus. So, but if you are using a toxin in the inactivated form, it becomes a toxoid. Yeah. So that's that. So so let's look at, I think let me see if this question can be answered at this point. Let's see. So this is a 20-year-old man. So after this question, we'll just take a break and come back. So this is a 20-year-old man who is brought to the emergency department for evaluation of a animal bite. He was hiking earlier that day and he was beaten by a raccoon. He says that the attack was unprovoked and the animal ran away after the encounter. Immunization are up to date. His immunization record shows he has received 3 doses of DPT as a child and Tdap at the age of 16. No distress. Temperature is 36.9. Everything is good. There's a wound on the lower extremity with active bleeding puncture site. The wound is thoroughly irrigated with normal saline and cleaned with antiseptic and bandage. What the following is the most appropriate next step. So what do we need to do for these patients? So somebody came with an animal bite. He was hiking when he was bitten by a raccoon, and he says that the attack was unprovoked and the animal ran away. You know, and he told us that he has received 3 doses of DPT as a child, and he had received another tetanus, diphtheria, HLA, pertussis vaccination at the age of 16. So now, what is this? This one that this person is receiving at 16. What is that called? Anybody? What's that going to be?
Maybe the booster.
That is going to be the booster. That is going to be the booster. So now I want us
Okay.
to look at this question well. Now, because this guy has been beaten by a raccoon and immunization is up to date, and they cannot get that raccoon, what is the immunization that this guy is due for first, like that? Anybody?
Rabies vaccine.
Rabies, but what are we going to give him? How are we going to give the prophylaxis? Is it just vaccine alone, or with immunoglobulin, or
The immunoglobulin and the vaccine.
Alone.
Just the vaccine.
just the
alone.
vaccine alone? So our answer is going to be option right. Option
D.
D.
Yeah.
Good. So because they told us that, so I'm going to mention something. So that should be the logical answer, right? Now, this guy is not going to be due for tetanus at all. Why?
The booster was given less than 10 years.
10 years.
Exactly. But we're not going to be using less than 10 years, my people. It's not less than 10 years, my people. It's not less than 10 years that we are using here. What are we using here?
He has gotten up to 3
Yeah.
doses.
Eh?
We
Sorry,
use
say?
it. Yes.
You are using 5 years. Why? This is a dirty wound. So that means that if they change this age to so it's 20 years. If they change this age to 14, so someone that's saying 10 years, do you think that this person will not get tetanus something? If they change it to 14 years, do you think this person will not get tetanus?
He will get it.
He will get
Yes.
it. He will get it. Because you have to look at the wound. That's the first thing about it. Look at the wound. Is it clean or dirty? This guy was beaten by animal, by raccoon. Raccoon will never brush teeth since when they don't burn out. That's a dirty wound. So you might need to consider for that kind of approach. Now, there's something I wanted to say here. Now, the answer to this question, my people, is this last option, but it's very controversial. And the reason is because they said that, if I can remember well, they said that the rabies immunization is not part of the routine immunization that they get. But I feel that that's not very good, to be testing. It's not part of. So the fact that they are saying that immunization is up to date, it doesn't mean that this person has been immunized against rabies. But I know that we cannot get this kind of question. So, that's just to open our mind. So that's why they are giving both the immunoglobulin and the vaccine. But it's not a very good question, to be honest. I was not impressed. Yeah. So let's look at this one. An 8-year-old boy is brought to the emergency department 3 hours after being beaten by his neighbor's dog. He was chasing the dog with a stick when it attacked him. He has fed the dog on multiple occasions and it has never beaten him before. His father saw the dog 2 hours after the incident and his behavior seemed normal. There is no personal or family history of serious illness in the family. The last vaccination the boy received was against varicella 2 years ago. He has never been immunized against rabies. Okay. I like the way they spelled it out here. It makes sense. So, he is not in acute distress. Vital signs are within normal limits. Examination shows a 2 cm puncture wound on his left calf. There is minimal erythema around the wound. The remainder of the examination shows no abnormality. A complete blood count is within reference range. The wound is irrigated and washed with saline and chlorhexidine solution. Which of following is the most appropriate next step in the management? What do we do? Anybody?
Observe the dog.
Observe the dog for 10 days. It's as simple as that. Observe that dog for 10 days. So, if they tell us now in the question that the dog has been immunized against rabies, what do we do?
You don't do anything.
Don't do
We don't do anything. The boy can go home. That is it. No catch. Observe the dog for 10 days. You cannot go and euthanize dog. Dog is not a wild animal. If you go and euthanize the dog, the owner will not even. All these white people, they don't joke with their dog. Person can go to jail because of that. Go and euthanize dog. Okay. So a 35-year-old woman comes to
So,
the.
excuse me, sir. So the patient will not receive anything because they say the patient has never been immunized. And
Yeah. So the thing is, before we know what to do, we need to
Okay.
know, the dog that has beaten this patient, is the dog rabid or not? And the way we can know is to observe that dog for 10 days and see if the dog is going to develop rabies sign. So if that dog develops rabies sign, we know that that guy that is beaten is likely to have rabies. So we'll now go and check the history of the guy. Are you immunized against rabies? So if the guy is immunized against rabies, what you are just going to give is what? Rabies vaccine. If the guy is not immunized against rabies, we are going to give rabies vaccine plus the immunoglobulin. Do you understand? So that was why I made mention that
Yes.
regardless of your immunization in rabies, you must get something. Do you get it?
Yes.
So that's
Thank
it.
you.
You're welcome. A 35-year-old woman comes to the emergency department because of an open wound on her left knee after falling while crossing a creek during a hike about 3 hours ago. She hit her knee on a rock and she had to crawl. Okay, she does not recall her immunization status. Let's look at the important things there. So there's a laceration just below the left kneecap. The skin is partially attached on the tibial side. The wound is covered with dirt and soil. There is erythema around the wound margins. The wound is thoroughly irrigated and debrided. Which of following is the most appropriate next step in the management? So the first thing to do is to do what? What are we going to do first? Anybody from our algorithm?
Check if it's a clean or dirty one.
Clean or dirty one.
We'll check if it's clean or dirty. So which one of it is it?
Dirty.
It is dirty.
Dirty.
Okay. So what's now the question we are going to ask ourselves?
Vaccination.
Immunization.
Exactly. Now, this one does not recall our immunization status. What do we think we are going to do?
Take it that she's not.
Take
Take
it
it
as
that
she
she's
is.
not. Thank you. So what are we giving?
Then
Both
immunoglobulin
and
and
That is it. So you give
Vaccine.
both. So what option are we picking?
D.
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 Mhm.
D for dog. So give both the immunoglobulin and the vaccine. Assume that once you ask them, you have a very low latency. Once you ask them, have you vaccinated? If they tell you they don't know, they have forgotten, just assume that they've not gotten it. It's better. Prevention is better than cure. It's better you quickly prevent it. So assume that they are not vaccinated at all. Then you follow that approach. So you give both the immunoglobulin and the vaccine. Now let me twist the question. If the wound was clean wound, it is not contaminated with soil, and the girl does not remember her immunization status, what are we going to do for this patient? Which option?
the vaccine only.
Just the
Vaccine only.
vaccine.
God
C.
bless you. There's no way USMLE can. I don't know how they want to twist it. Your own is just to go and be doing algorithm. Step 2 is all about algorithm. The more the algorithm you know, the better you are going to be. And these algorithms are not something that you even have to cram. There's things that you can even reason out. So that is it. So let us take a break.
Dr. Ban,
Yes.
please, I have a question on that algorithm.
Okay.
On that, the one for
The
the
rabies.
the tetanus.
Okay.
Yeah. So for this one, if it's a clean wound, what do they actually mean by otherwise?
So other ones means dirty, something that is not clean.
Okay. So the one that goes, I'm talking of the one where your arrow is. So we should assume it's not clean. After it says clean, if it's a clean minor wound, then it goes into 2 divisions. The lower one that says otherwise.
Otherwise, so what they are saying is that, okay, so now we have 2 possibilities here. If this person has not taken 3 lifetime toxoid, so the otherwise is going to be if the person has taken 3 lifetime toxoid.
Okay, thank you.
You get it now. That's it. It's just the opposite. So once you have taken 3 lifetime toxoid and your last toxoid is less than 10 years, so you are going to fall to otherwise, then no prophylaxis.
Right.
So
Mm.
that's the way it works. All right. So let us take like 30 minutes break. We're almost done. We're not really going to. We're almost done for the day. So let's just come back by 16:50 in 30 minutes. We'll just round up and continue. Thank you, everybody. All right. Are we back? Hello.
Yes, we are.
Okay. So we are moving on to the other bites and the stings, and we have for the B and the WAPs. So what that can cause is just anaphylaxis. So what we should just do is just to give them, epinephrine, high-end epinephrine if we see feature of anaphylaxis, which you already know. And we can also add some adjuncts, which is like the antihistamines and steroids. So for the spiders, we have to type the black widow and the brown recluse. So from the word recluse, necrosis, think about necrosis, recluse. So there's going to be skin necrosis, feature of DIC. So just apply some cold compress to that area to slow down the necrosis. They can use Dapsone, but we should rule out GCPG deficiency. And of course, if an area is necrotic, always debride. Remove that necrotic area. That's for the brown recluse. Then for the black widow, I used to look at it in the form that is the one that will make you shiver. So it can cause spasm, and the abdomen is going to be also rigid. Any part where you have that bite, the area is going to be very, very rigid, and that area can also undergo spasm. And because of the spasm, we can, although it's not very routine, they can give in some benzo, but the most important thing to give is antivenin. Give antivenin to neutralize the venom from the spider. So black widow that made them shiver, undergo spasm with rigid abdomen, give the antivenin. For the brown recluse, where they have, necrosis, debride, and use Dapsone, and also apply cold compress. For the scorpion, so scorpion affect neuromuscular area and autonomic. So they have problem with the neuromuscular part, the nerve, the muscle, and the autonomic nervous system. So for the nerve, they can have cranial nerve dysfunction. It could be affecting cranial nerve 12, they find it difficult to swallow. Cranial nerve 9 rather, 9 and 10, difficult to swallow. They could be having like abnormal high movement. For the motor one, so neuromuscular. Neuro is the nerves, muscular is the one that the muscles will be excessively contracting, like spasm. So you can even think it's like seizure, but it's more like spasm that they're undergoing. So you can give them benzo for that one. Then the autonomic is like hypersalivation, tachycardia, excessive sweating. So if you are seeing neuromuscular problems with autonomic symptoms, think about scorpion bite. So the same thing you do for the spiders, give antivenin. Give antivenin. Very important. Okay. Then snakes. Snakes. So we have the crotaline snakes, we have the rattlesnakes and the copperhead. They are example of snakes. So they can cause the area where they are biting, where they insert the venom, can undergo local necrosis, erythema. They can have shock. They suddenly become hypotensive. They can have DIC. It can be that bad. So regardless of what we are seeing in the presentation, once they tell us that okay, the person was bitten by a snake or something, just go and administer the antivenin, just like we have been picking. And that's usually the Crotalidae polyvalent immune fragment. So, and you keep that affected limb above the heart. So, if it's the hand, you raise it up. If it's the leg, raise it up. Sorry, I said raise it up. Put it down. Sorry, not raise it up. Keep it below the heart, because if you keep it above the heart, it's going to easily go to the heart, and from there the heart can pump into the other body parts. So keep it below the heart. Very, very important. Then all those things that people usually do, like tying tourniquet, try to inject that area to be sucking out venom. Please don't let us put all those pick all those things. So don't apply any compression band. Don't apply any tourniquet. Don't do fasciotomy. They are outdated treatment. So just keep that area below the heart and administer your antivenin. That's what you do. For dog and cat, don't forget you always want to give vaccination for tetanus and rabies. And because of the fact that they have a very high chance of causing infection, you must give them some prophylactic agent. And that is amoxiclav. I've emphasized this. Amoxiclav, very important for them. So sometimes you might want to do imaging for cat bite, because cat teeth, it's very sharp, so they can get retained. So you might want to do imaging to look for any retention. Human bite too, amoxiclav, same thing, amoxiclav. So very common people that have maybe they are boxing and they mistakenly eat the mouth. That can also be like a source of infection from the human flora. So they can have infection from there, and you have to give amoxiclav to cover for it. For the rodent, low risk, so just local wound care. For shellfish, think about necrotizing fasciitis, because they start having features of necrotizing fasciitis, the crepitus, the bullous lesion, skin discoloration, very painful skin, with bullae, and the person has been exposed to salt water. They are playing with shellfish, know that the organism is going to be vibro bonificus. Just like other forms of necrotizing fasciitis, you want to quickly go and debride. So debride and give IV doxy and ceftriaxone. So that's for vibro bonificus. So the commonest risk factor, usually they have some underlying liver problems. We did this in microbiology step 1. So liver problems, liver cirrhosis, hemochromatosis, and all those, and then iron overload, situations too, like hemochromatosis, liver cirrhosis. They are very high risk for triggering shellfish infection, like this vibro bonificus infection causing necrotizing fasciitis. All right. So moving on to toxicology. So you want to resuscitate a patient that is poisoned, you quickly want to do your ABCD, you know, sometimes if they are having like altered sensorium, unexplained seizure, you want to look at consider drugs. Either the person has been withdrawing from drug or the person has been overdosed on a particular drug. So you want to do like a urine toxicology screen quickly. And of course, don't forget ABCD always takes precedence over anything. That's the first thing you do, you know. And if you connect your ECG when you're at the level of the C, you can connect your ECG leads and quickly look for some arrhythmia. So that can be seen, you know, the ECG, like for example, somebody having like tricyclic antidepressant overdose, you can see like feature of ventricular arrhythmias and all those things, widening QRS complex, you know. And you also want to do a thorough neurologic examination. Under the D, you quickly want to look at the pupils, you want to look at the muscle tone, the reflex. For example, somebody that is on let me say like opioids now, they can have pupillary constriction. Someone that's on TCA, they can have pupillary dilatation. You know, some people will have like reduced muscle tone and reflex, very common in opioid too. They can have reduced muscle tone. Benzo, they can have reduced muscle tone. So muscle tone can be increased in somebody that's having like serotonin syndrome, maybe from a combination of tramadol with MMDA or combination of linezolid with fluoxetine or something. So they can have increased muscle tone and reflex. So what do you do next? One thing that you have to consider, especially if somebody is poisoned, is that maybe alkali, base, acids, alcohols and all those things, you want to decontaminate immediately. So if the drug is in their body parts, you want to remove the clothing, remove it, and if it's usually less than between 2 to 4 hours, usually less than 2 hours, you might want to give activated charcoal. So less than 2 hours after the injection, you might want to give activated charcoal. And what that one is going to do is just to reduce, it's an adsorbent. So it's going to attach to that chemical and reduce its absorption further into the blood. So they administer it orally, you have to take it, activated charcoal. But there are some exceptions. You don't give it in someone that is taking any, that had like poison from any metal. Lithium, iron, lead, you don't give it. Lithium iron, forget about it. Don't give activated charcoal. Acid and alkali, don't waste your time with activated charcoal. It's not good. Alcohols too, you don't take it. So just remember metals and alcohol. Metals, alcohol, don't give activated charcoal. And alkali and bases and acids. Alkali, bases, alkali, acids, metals, alcohol, don't give activated charcoal. The commonest one for activated charcoal is like maybe they have like salicylate poisoning, or they have poisoning from barbiturate. So barbiturate, salicylate, acetaminophen. Those are the ones that you can consider activated charcoal. So care should be taken in people that are lethargic. Yeah, this point is very, very important. Once you can identify in the question stem, you see, just mere looking for the sensorium in step 2, you can be guaranteed that you are going to get a lot of questions right. Once you find out that, because that changes everything. So once you see that this patient is lethargic, you don't want to be putting something in their mouth. So that's not the time to be considering giving activated charcoal, even if it's within the 2-hour window, because they can aspirate it. So never pick lavage in any of the option. I don't even want to know. Don't pick lavage. Don't pick Epicac of syrup or something. It's not useful. Epicac of syrup, lavaging, they're always wrong. Don't even think about them at all. So what are the high toxic agents that we must know? Number 1 is carbon monoxide poisoning. So this one is very common in people that get exposed to some fumes, automobile fumes, smoke from maybe furnace, fire, burning bushes, burning buildings, barbecues. All the appliances that are connected are not removed in poorly ventilated homes. Carbon monoxide just there. Generators, very common in Africa. Generators, fume, carbon monoxide poisoning. And they tell us in the question that the patient is now developing headaches, confusion, nausea, dizziness, impaired concentration, impaired thinking. they're having myalgia, you know, you can have a high index of suspicion for carbon monoxide poisoning. So you might want to ask people living with you, are they also feeling the same thing? So you know that, oh, this is likely to be carbon monoxide poisoning. Everybody there is breathing the same air. So they could have been all collectively exposed. Then you want to look at, in your assessment, ABCD, you want to look at the area, look at the airway. Are you seeing anything in the nose? Is it appearing singed? Singed like burnt nasal hairs. Look at the face, is it burnt? Is there any presentation of hoarseness, wheezing, carbonaceous sputum? So they're having sputum production is looking blackish. In this kind of people, anybody with this, you must intubate that person. Look at the nose. Of course, this kind of person will not even be talking. So they're having facial burns. That's not the part to be doing NIPPV. There's facial burn already. How you want to apply the marks? So there's wheezing. It means that there's already having like laryngeal edema. So you quickly have to go and secure that airway. So the expression of carbonaceous sputum, go and secure that airway immediately. So to make your diagnosis quickly, the most important test you want to order is your carboxyl hemoglobin level. And by doing your CO oximetry, this CO oximetry is so useful that it's able to tell you level of oxygen, level of deoxyhemoglobin, deoxyhemoglobin, oxyhemoglobin, carboxyhemoglobin, methemoglobin, all of them, you'll be able to obtain it with your CO oximetry. So very important stuff. And it's going to be normal if you have less than 5%. So less than 5%. So the amount of the gas that is accounted for by carbon monoxide is just 5%. That's okay. And in smoker, because smokers generally have more carbon monoxide than normal people, so their own value is 10%. So keep it less than 10% for smokers, keep it less than 5% for non-smokers. Then sometimes if you're evaluating for carbon monoxide poisoning, you might need to do ECG, especially in the adult, because one thing about carbon monoxide poisoning from Dr. Abarinde's explanation of our recipe, if we have heard it, I'm sure he will have taught us, is that what carbon monoxide does is to bind to hemoglobin, and it will increase the affinity of hemoglobin. Carbon monoxide on its own has like 250 times the affinity oxygen has for hemoglobin. It has 250 of that. So it can readily bind to hemoglobin, not creating adequate space for oxygen. So let us look at its illustration. So if this hemoglobin is 4 spots, 1, 2, 3, 4, and carbon monoxide comes, carbon monoxide is not competing with oxygen for all these 4 spots. So carbon monoxide is going to occupy like 2 spots, or let me say 3, because of the high affinity, remaining 1 spot for oxygen. Now, what it will now do is that it's going to allow oxygen to bind to this 1 spot, but there's going to be some kind of conformational change that this hemoglobin will not even be able to release that oxygen to the tissues. So that means that it's going to shift the bulk off to what part? Is it right or left or middle? Anybody?
To the left.
To the left. So the cough is going to shift to the left because it's not readily going to release that oxygen. That is what carbon monoxide does. Now, so if oxygen is not readily released to tissues that need it, like the brain and the heart, they are going to suffer problem. So because it's not being released to the brain, there's headache, there's confusion, there's seizures. Because it's not being released to the heart, there's chest pain. Very bad chest pain, like mimicking angina. So there's going to be evidence of cardiac ischemia when you connect your ECG. In fact, when you are seeing that, it is automatically an indication to go and start something that we're going to talk about shortly. Now, you must also check, are they pregnant? Anybody with carbon monoxide poisoning that is pregnant, the treatment changes. So you have to order HCG test to see, are they pregnant? You have to do ECG to see, is there evidence of cardiac ischemia? SC segment changes. Are you seeing that? You know that, oh, this guy is already becoming ischemic. I have to do something fast. How do you treat them? So if it's just normal, not too bad, not severe, just place them on 100% oxygen via face masks. If you can apply the face masks, apply it and give them 100% oxygen. and you continue to monitor your carboxyhemoglobin level until it falls to normal. But there might be some situation where you need to deliver 100% oxygen in a pressurized chamber. That's what you call hyperbaric oxygen. And that is if somebody is pregnant. If somebody is pregnant, in fact, the affinity carbon monoxide have for hemoglobin quadruples because it likes a lot of fetal hemoglobin. So you have to be very careful, just giving on normal 100% oxygen via face mask. So you have to go and put them in the hyperbaric chamber. If somebody is already having problem with CNS or cardiac ischemia, you have to immediately consider for hyperbaric oxygen. They're having seizures already. Go and give hyperbaric oxygen. Or you measure the carboxyhemoglobin level. We've said it for normal people, it should be less than 5. And for smokers, it should be less than 10%. You are now getting value of 25%. You are now picking 100% oxygen via face mask in the exam. That's the problem. So, more than 25% hyperbaric oxygen. If you are seeing any feature of airway edema, like wheezing, hoarseness of voice, singe nasal hair, carbonaceous sputum, immediately go and intubate them. Immediately go and intubate them. Now, there are some lab values that might be confusing in people with carbon monoxide poisoning. This could be a RU question. Some people will be confused in the exam, but it's very simple. Carbon monoxide poisoning, when you measure, they will tell you in the question that they measure oxygen saturation and it is normal. Yes, it will be normal because what pulse oximetry is doing is just to measure absorption of light at a particular wavelength. That's what they are doing. So the problem with the pulse oximeter is that it does not have the ability to differentiate between oxyhemoglobin and deoxyhemoglobin and even, no, let me say it doesn't have ability to distinguish between oxyhemoglobin and carboxyhemoglobin. So even though the 3 sides of the hemoglobin is occupied by carboxyhemoglobin and only one side is occupied by oxy, it doesn't see it as carboxy. It will think that all of them, they are oxy because they absorb light at the same wavelength. So our pulse oximeter is going to be confused and it's going to record the SpO2 to be 99%. And some people will think that they are winning. No. It's just because that pulse oximeter cannot differentiate between carboxyhemoglobin and oxyhemoglobin. So you know what you are even looking at in the exam. In fact, when they tell you that oxygen saturation is low, you are worried because that's not what you expect. It should be normal unless there's another problem entirely. Now, there's another thing again. The PaO2. The PaO2. What did we say about definition of PaO2? Anybody remembers? Anybody remembers? I want to see. What did we say about PaO2? What is it? The small a.
Pressure of
Oxygen in the artery.
arterial oxygen.
In the artery. The one bound to hemoglobin 2 is in the artery. So what is it?
Dissolved in blood.
Dissolved. That's the
That's
word.
dissolved.
That is the
Yeah.
word. The one that is dissolved in the plasma. You see, the thing is, this one that is dissolved in the plasma, it is not affected because the problem is with hemoglobin. So this one is normal. They will give you that they do ABG. They do ABG. And what? PaO2 is normal. You are not worried. The only way you can pick that problem, the only way you can pick it is when you do your CO oximetry. Your ABG is not going to help you. Your SpO2 pulse oximetry is not going to be helping you. The only thing that can help you is when you do your CO oximetry. You look at the volume or the percentage of your carbon monoxide. Is it more than 5%? Oh, that is the problem. This person is smoking. Is it more than 10%? That is the problem. Oh, it's very high. 25%. This guy needs to benefit from hyperbaric oxygen. That is carbon monoxide poisoning. So they will tell us that the person is having headaches, confusion, seizures, and very important, cherry red spots. Although it is very rare, but it's a very good clincher. Once you see cherry red spot in the skin, think about carbon monoxide poisoning. Now, let us quickly look at the question to see if I have driven home that point very well. So this is a 65-year-old woman who is brought to the emergency department by her husband 1 hour after he found her in the lakeside cabin with nausea, headache, and agitation. When he left the cabin 6 hours ago to get more firewood, she did not have any symptoms. Medical history is remarkable for hypertension, type 2 DM, migraine, and medication are lisinopril, met, ibuprofen. But she ran out of antihypertensive medication over the weekend. Temperature is 37.1, pulse is 110, respiration 21, BP is 154. Pulse oximetry on room air shows an oxygen saturation of 98. She's confused. Oriented only to place and person. She recalls only one of 3 objects after 5 minutes. Gait is unsteady. Remainder of the reaction shows normality. Which of following is the best next step in the management? Anybody? What are we going to do for this person? Hello? Are we there?
Hyperbaric.
Yeah.
Why are we quiet? Is it confusing? There's nausea, headache, and agitation. And that was after the man left her in the cabin to get more firewood. Yeah, I get it. They did not really give us any focus, but that's the focus, the firewood. They are burning fire somewhere, And suddenly she became confused with headache, agitation, and nausea. She's now confused now. And the oxygen saturation is still 98%. She's having encephalopathy. She recalls only 3 object, and the gait is unsteady. So there's some neurological stuff in someone that is in a cabin that's getting firewood. So even if we don't know it, we'll now go through the option and see what they are testing. Look at intravenous hydroxychloroquine. That's testing on that thing. Prucide, triptan. So which one are we picking here?
Hyperbaric.
Hyperbaric oxygen.
Oxygen
So
therapy.
because of the neurologic problem, you have to give hyperbaric oxygen. So this is an example of carbon monoxide. But it's not very well spelled out, but we need to just have high index of suspicion for it. Yeah. Okay, so moving on to MET. So this is hypoxemia, coming from exposure to oxidizing agents. Very common ones like local anesthetic, dapsone, nitrite. They're very good example. And the problem here is that we are converting Fe2 plus to Fe3 plus. You have oxidized hemoglobin from Fe2 plus state to Fe3 plus state. And that affects oxygen transportation. Now, they are going to tell us that the person has been exposed to local anesthetic agents, lidocaine and all those things, nitrite or dapsone. And the person is going to be cyanotic. The person is going to be cyanotic with chocolate color block. That block is going to appear very dark like chocolate. Think about MET once you see that. Always think about methemoglobinemia when you see that colored blood. So, just like carbon monoxide poisoning, the physician should not rely on pulse oximetry or PO2. That physician is just whining himself because they are not going to see anything. In fact, they will be confused. Now, the changes that happen in MET is that the pulse oximetry is not going to show normal SpO2. That's the difference. Now, this one is now going to show a low SpO2. Why? The reason is because MET can absorb light at wavelength of both oxy and deoxy. So it's going to be as if it is a mix. So if you mix both of them together, it's going to be dropping to like something like 84%. So you get a low oxygen saturation with methglobinaemia. If you do the PaO2, it's going to be normal because it doesn't affect the fraction that is dissolved. It doesn't. So what you can do again is to do your CO oximetry to actually look at the level of your methemoglobin. So the treatment is very straightforward. It is the most straightforward one. Just give methylene blue. It is a reducing agent, and it will reduce your Fe3 plus to Fe2 plus. So Fe3 plus is methemoglobinemia. Fe2 plus is normal hemoglobin. So if you don't see methylene blue there, we are going to see what? Anybody?
Vitamin C.
Vitamin C. So you speak of vitamin C or met. Now, sometimes you might not see vitamin C there. So what you do is that you go and do exchange. You see exchange transfusion there, pick it. But before you consider doing exchange, go and look for your vitamin C or your methylene blue. So if it's not there, go and do exchange. If you are not seeing exchange, go and pick hyperbaric oxygen. It cannot go beyond that. That is met for you. Now, let us look at, I think, do I have a question there? Okay, I think I do. Yes. So, this is a 48-year-old man who comes to the emergency department because of one day history of weakness, shortness of breath, and blue discoloration of the lips, cyanosis. Medical history is remarkable for dermatitis, treated with dapsone. Okay, we know the focus now. Pulse oximetry on room air shows saturation of 85. Is that expected or not?
Expected.
Yes,
It is
it's expected.
So ABG shows pH of 7.4, PCO2 of 17, PO2 of 99. Is that expected or not? PO2 of 99. Is it expected? It is
Yes,
expected. So which
yes.
of following is the most appropriate next step in the management of this patient? So what do we do for this patient?
Ascorbic acid
Ascorbic
therapy.
acid first.
Acid.
Ascorbic acid first. If you don't see that, methylene blue. Before you start looking at other things. All right. Very nice. So, we can see the focus there. That one is because this guy was on dapsone. He's taking dapsone. Yeah. Now, so there's a statement here that says that inducing methemoglobinemia using nitrite is a treatment strategy for cyanide toxicity. So I don't think that we are going to talk about cyanide toxicity here, but cyanide toxicity can present just like all this carbon monoxide stuff, and it's very common in people that have exposure to like burnt textile, carpet, and all those plastics. So there's going to be a burning fire somewhere, not really fumes like that, but maybe burning carpet, burning textile, burning plastic, carbon monoxide, cyanide poisoning. So what is going to happen with cyanide poisoning is that cyanide is going to come and go and bind to cytochrome C in the electron transport chain, cytochrome C. Now, when it inhibits the activity of cytochrome C, the electron transport chain in the mitochondrion fails. So oxygenation is reduced and, generation of energy in form of ATP is reduced. So the person will start having all those manner of symptoms, headache, nausea, vomiting, seizures, blue skin, and all those things. Cyanide. So now we need to be able to create a strategy to attract this cyanide from this cytochrome C. So what we do is we have discovered that cyanide likes methemoglobin. It likes binding to hemoglobin in its met form. So what we are now going to do is we now induce formation of methemoglobin from hemoglobin. So what we are going to do is just to expose the person to amine nitrite, so that we can oxidize Fe2 plus to Fe3 plus. So we are going to get methemoglobin. So cyanide is now going to combine with that methemoglobin, so that it can free the cytochrome C so that they can be working on their own. That's one approach. Another approach is by giving hydroxycobalamin. So once you give hydroxycobalamin is going to attract the cyanide, and it's going to form cyanocobalamin, which is vitamin B what? B12. And that will be readily excreted in urine. Those are the algorithm for management of cyanide poisoning. You either give nitrite, to induce formation of cyanide combining with what's it called? Hemoglobin, or you just give hydroxycobalamin that will just, combine with cyanide and they will form cyanocobalamin and they'll be excreted in urine. Very important. So, moving on to antidote and management of other So let's just look at this, and we call it a day from here. So now this is just more like a table. So the most important one here is acetaminophen. You cannot go for your exam, you don't know acetaminophen management. It's very dangerous. So two overdose, it's either acute or chronic. So if it's chronic, this doesn't have taken as there's little you can do, just be giving supportive treatment. But if it's acute, so what you want to do is to ask, when did you take this acetaminophen? How many did you take? So this person, if this person takes that drug within 4 hours, you can administer activated charcoal to reduce the absorption. Then once it's 4 hours, immediately you start plotting what we call the Ramsey, the Romack-Matthew plot. You open a chart and you start plotting that Romack-Matthew plot. So this is talking about the concentration of the acetaminophen with time. We can see that the time is starting from when? When is it starting?
4 hours.
So
4
I'm saying that
hours.
so that we would have that at the back of our mind. 4 hours. It starts from 4 hours. So you give it time because it's expected that within 4 hours, that's when the acetaminophen gets absorbed into the blood. So if a person comes now and they tell me that they took the acetaminophen 1 hour ago, I'm not going to open this chart. I'm going to wait till 4 hours. You will see that in the option. Wait till 4 hours. Speak it. Don't be saying that you don't know what you are doing. Wait till 4 hours before you open your chart. So you now look at the level with respect to your treatment line. This is your treatment line. So immediately what you are plotting is getting above the treatment line. You have to go and administer N-acetylcysteine. So let's go back. I've explained that. So now somebody comes in within 4 hours. What initial stuff can we give? Activated charcoal. Provided that they are not having other sensorium or something that can affect the activated charcoal, give them activated charcoal. You also ask them, how much have you taken? If this person has ingested more than 7.5 grams. So I know that one tablet is 500 milligrams. Say if they take 20 tablets, that's going to be how many? 10,000. Is that 10,000? So I think it should be 15 for 7.5. So if somebody takes 15 tablets, that's 15 times 500. So that's going to be 7,500 milligrams, which is equivalent to 7.5 grams. So it means that if somebody takes 16 tablets, you are going to assume that that is going to be more than 7.5 grams. So in that kind of situation, you don't want to be starting with activated charcoal. Immediately, you want to administer N-acetylcysteine. If the person has not taken up to that, but you waited for 4 hours, you plot your cough, and it's more than treatment level, which is 150. The treatment line is 150. You administer your N-acetylcysteine. You can see that this is 150. So anything above 150 is crossing the treatment line. So you want to administer your N-acetylcysteine. But if any of these criteria is not met, you can give attenuated charcoal, provided it's within 4 hours. So I think we know the making of how N-acetylcysteine works. I don't think we need it. The last step, I think we know, most of us will know it, right? We know it, right? I'm not getting any response. Hello?
Not really.
Okay. So now, if somebody overdoses on acetaminophen, they produce some metabolites that we call NAPQ high. So NAPQ high is N-acetyl something NAPCO, we don't need it. Me too, I've said I've forgotten. NAPQ high, so that's the metabolite, right? So this metabolite is being neutralized by antioxidant called glutathione. So somebody takes acetaminophen, they generate a lot of NAPQI. Glutathione is always there to help us take it out. But when it gets beyond a certain level, it will deplete all the glutathione. So the only way you can reconstitute glutathione to neutralize it is by administering NEC. That's the function of NEC. Somebody taking acetaminophen and the person already comes in with liver problems, liver markers are deranged, quickly want to give NAC. And of course, if liver markers are deranged and the person is having encephalopathy, prolonged PTT, what's the diagnosis? GIT. What's the diagnosis? Anybody knows? Somebody takes a lot of acetaminophen and the person comes to us with prolonged PTT and INR with features of encephalopathy. What is the diagnosis? This is GIT.
Acute liver failure.
Acute liver failure.
Which liver failure?
So what do we consider for that person? What's the best next step for that person? Anybody?
Liver transplant.
Liver transplant. Refer to a facility with liver transplant. That is what you can do. That is it. So acid and alkali injection, we do our normal ABCD, remove that affected clothing, and consider for endoscopy immediately. Usually within 6 hours. Because if you do it too early too, you'll not see anything. But if you do it within like 6 to 24 hours, you'll be able to see what is happening, the inflammation around those things. But you don't want to do it after 24 hours because if you go and do endoscopy after 24 hours, you can perforate it. So, don't try to give anything that will neutralize. Don't pick any option that neutralize the acid because you generate too much heat that's going to worsen the problem. So, if the highs are involved, just irrigate. We have talked about that. Always irrigate. If it splits to the highs, irrigate. So, don't give syrup of Ipecac, it's going to be wrong. Don't give lavage, it's going to be wrong. Just look for supportive care, remove clothing into endoscopy. That is it. Provided it's not more than 24 hours. Don't give charcoal. Wrong. We have said it. Acid and alkali. Wrong. Activated charcoal. Metals. Wrong. Activated charcoal. So, organophosphates, they are anticholinesterase. So, they inhibit the activity of acetylcholinesterase. So, there's a lot of what's it called? What's it called? Acetylcholine, in circulation. So they cannot, because if you inhibit acetylcholinesterase, you'll not be able to break down the acetylcholine again. So a lot of acetylcholine acting. So the person is going to be having feature of cholinergic crisis. What's the acronym? Anybody remembers the acronym for cholinergic crisis? What's the acronym?
Dumbbell.
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 So just look at the feature of dumbbell. Once you see dumbbell, all those diarrhea, I don't know what's in urination, Abi? Is it urination? Diarrhea, urination, meiosis, B, bradycardia, and all those things. So once you see all those cholinergic, once you know it's not something like that. Once you see all those cholinergic features, this guy is having cholinergic problem. So immediately you want to consider anticholinergics like atropine, especially for the muscarinic symptoms that we have been talking about. Diarrhea, meiosis, frequent urination, all those muscarinic give atropine. But if the person is having paralysis, you want to reconstitute the nicotinic, you want to block nicotinic action, then you have to give your palidoxan. So, and the way palidoxan works is to reactivate your acetylcholinesterase. So it's very good for the motor presentation. Very important distinction. Don't forget it. Then for anti-muscarinic or anticholinergic agent, they've taken a lot of anticholinergic. Maybe they took TCA that have anti-muscarinic agent, or they took some anti-muscarinic, scopolamine, atropine overdose. So you have to reconstitute them by giving physiostigmine, not pyridostigmine. No. Where do we use pyridostigmine? Anybody?
It gets rid of myasthenia gravis.
Myasthenia gravis. So there is Y, Maya, pyrido. There's Y. Oh, that one doesn't work. It doesn't work because there's Y twins physiostigmine. But don't worry, it will come naturally. So physio for the anticholinergic, pyrido for the muscarinic, for the myasthenia gravis. It's important we know all those distinctions because you can be confused in the exam. They will put both of them there. Someone will now be racking, which one? So physio is for the anti-muscarinic toxicity. Pyrido, the one with the first Y, is one for myasthenia gravis. So watch out for antihistaminic drugs, very common because most of them, they have anticholinergic activity. So they can be the cause of anticholinergic agent toxicity. So people with arsenic commonly toxicity. So they just tell us that the person is working maybe industrial area, taking some water from a pipe or something, working in landfills, and suddenly the person start developing garlic breath, nausea, vomiting, diarrhea, dermatitis, peripheral neuropathy. Think about arsenic poisoning. I want to consider giving Susema or Damecapro, depending on the level. So beta blockers, everything is just high. There's tachycardia, there's hypertension. Now, because if you give beta blockers to the airway, there's going to be bronchospasm. So we know that this guy is on beta blocker overdose. So what you give is glucagon. Glucagon will help us reconstitute the CMP. That's the way it works. And you bring the person back. Barbiturate and salicylate, the same treatment algorithm. Alkalinize the urine to get them out. You can dialyze, give activated charcoal initially, and provide supportive care. That's just it. Initially, you can give activated charcoal to reduce absorption, alkalinize the urine so that you can excrete them, and place them on dialysis if it's refractory. Benzo, supportive care only. If there's a need for oxygenation, give oxygen. If there's a need to intubate due to excessive sedation, intubate. That's the supportive care you can do. Don't pick Flumazenil. It's going to be wrong. Many people will go and be picking Flumazenil confidently. You don't. You have to be very careful with it because it can precipitate withdrawal seizures. So the body is just going to assume that you have blocked all the benzodiazepine suddenly. So they will start precipitating withdrawal syndrome. There can be a problem. Especially in people with chronic, you want to be very careful. So don't use Flumazenil in chronic benzodiazepine. So just go for something that talks about supportive care, intubate, oxygenate, and all those things. So for copper, arsenic, lead, penicillamine, for them. Cyanide, I've talked about cyanide. Hydroxychlorolamine, the nitrite, they would work. Digitalis, just give Digabind, or digoxin immune FAB fragment. So to neutralize it. So don't correct hyperkalemia or hypocalcemia, which are effect of digoxin. Don't go and correct it. Immediately you give, because that can even worsen the problem. So because hypokalemia will allow digoxin to even further be ferocious. So you don't want to be correcting hyperkalemia and be leaving the digoxin there. Once you correct hyperkalemia, you bring it to hypokalemia, there's problem. So what you do is that you just correct that digoxin toxicity and you leave the electrolyte to restore. So because if we look at the way digoxin works, it inhibits the sodium potassium ATPase pump. And the function of the pump is to pump sodium out. So that means that if we cannot pump sodium out, we are going to be having a lot of sodium inside, right? So there's going to be high intracellular sodium. And the function is to pump potassium. Sorry, am I okay? Yeah. And the function is to pump potassium inside because the activity of that enzyme, that enzyme is to pump electrolyte against their concentration gradient. There's a lot of sodium already ECF. You are not pumping it outside. You need that enzyme to do that. And you need energy in form of ATP. That's why we call it ATP dependent potassium channel, sodium potassium pump, because you need ATP to move sodium against its concentration gradient to the ECF, and you need ATP to move potassium against its concentration gradient to the ICF. So it means that if that enzyme has been inhibited by digoxin, what is going to happen is that you can no longer pump sodium outside. So you have a lot of intracellular sodium. And you'll not be able to also pump potassium inside. You have a lot of extracellular potassium. So that means that this person is going to be having hyper or hypokalemia. Anybody? Hyperkalemia. So there's going to be hyperkalemia. And now, because of the fact that there's a lot of sodium inside, you don't need the activity of the sodium calcium exchanger again. Because there's a sodium calcium exchanger that is inside. And what that exchanger does is that they want to try to maintain normal sodium inside. And what they do is that they will move calcium out so that I can bring sodium in. But now that you have a lot of sodium in already, the activity of this exchanger stops. You don't need to take out any calcium outside. So you have a lot of calcium staying inside, and you have little calcium going outside. So there's going to be hypocalcemia. So those are the complications of digalis. So you don't correct those derangements. You just give your digabind or your digoxin immune FAB fragment, and they will correct themselves. Heparin, just give vitamin sulfate. It's going to be fine. Iron, just give desferoxamine, desferoxerox, and all those things. And what you are going to see in the question that will raise suspicion for iron is that they will tell us that they are seeing radiopaque tablet on X-ray, and the child is having hematemesis. And by the time they do labs, they are seeing metabolic acidosis. Why? Because iron affects electron transport chain too. So they will be forced to undergo anaerobic pathway leading to acidosis. So once you are seeing radiopaque tablets with acidosis, high anion gap acidosis, just go and pick iron toxicity. So lead poisoning. We know the feature of lead poisoning. I cannot be sick. Dr. Babande have said that 20 times. So Susima, EDTA, and Damecaprol. Any one of them. So methanol and ethylene glycol. The commonest presentation of methanol, they will tell us that this patient is having metabolic acidosis in the labs. Metabolic acidosis with vision problems. Methanol poisoning. So somebody is having metabolic acidosis, stones, like calcium oxalate stone or something. Think about ethylene glycol poisoning. So what you do is just to give fomepizole so that you can prevent them from being oxidized. You don't want methanol to be going to formic acid or formaldehyde that is causing the problem. And you don't want ethylene glycol to be going to oxalic acid, which is the form that is causing the calcium oxalate stone. So you have to inhibit the enzyme that oxidizes them. So by giving fomepizole. Or if you cannot give fomepizole, give ethanol. Why? Because the enzyme that oxidizes these guys, we call that enzyme alcohol dehydrogenase. So the ethanol is going to compete with them for that alcohol dehydrogenase. So it's going to oxidize ethanol instead. Instead of oxidizing methanol or ethylene glycol, it is ethanol that is going to be oxidized, which is good. We can still work with that. So rather than the toxic metabolite of methanol oxidation or ethylene glycol oxidation. So don't forget blindness and metabolic acidosis for methanol, and metabolic acidosis and stone formation, calcium oxalate stone for ethylene glycol. Very, very important stuff. Opioid poisoning, naloxone. In fact, most of the people that are unconscious, you have to pre-medicate by assume that they are overdose on opioid and give naloxone. Don't say that. The question did not say that there's meiosis, because I know that that's what many people will be looking for. But the question did not say that there's meiosis now. We cannot give it naloxone. Once we see a patient that is unconscious, the way their paramedics are transferring or something, they're already giving naloxone shots. Very, very important. Give it. So even if it's not there, it's not going to do any harm to the patient. Don't wait for meiosis. So salicylate, just do it like we are doing barbiturate. Our activated charcoal, urine alkalinization, dialysis. So how you are going to know this guy is high on aspirin or salicylate is when you start having nausea, vomiting, tinnitus. This tinnitus is high, ringing sensation in the ears, abdominal pain due to like ulceration. Think about salicylate. It can have AKI, salicylate. So TCAs, we are going to notice that this EG is going to show widening QRS complex more than 100. Or if there's a ventricular arrhythmia, just know that this guy has overdosed on TCA. They could be having anticholinergic feature like the dumbbells. No, not like the dumbbells though. I've forgotten. Anticholinergic features, just like we know, dry mouth, constipation and all those things. Anticholinergic symptoms. They could be having what do you call this? When there is no adrenergic symptom, what's the word now? Alpha 1, because these guys can block, alpha 1 receptors at the same time. So there's absent adrenergic activity. So you see something like orthostatic hypotension, They have anticholinergic activity and antihistaminic activity. So all those things, they go together. No, sorry, not antihistaminic. I'm wrong about that. Anticholinergic, antiadrenergic, and there's one more that I'm forgetting. I'm forgetting. I don't know if someone can remind me. Anybody can remind me? Psychiatry. It's under psychiatry. 3 things. TCA poisoning.
I think it's antihistaminic, anti-harm.
Antihistaminic. I'm forgetting those things. Okay, maybe we can confirm. Antihistaminic, antiadrenergic, and the anticholinergic. But I'm sure of the cholinergic. Yes. You know, you see all those anticholinergic, and you see the antiadrenergic, which is usually in form of orthostatic hypotension. So you can confirm the histamine. The histamine is not even very high yield. You might not even see the presentation in the question. So you're now saying widening QRS complex and ventricular arrhythmia. Have a suspicion for this. So immediately you are seeing widening QRS complex and arrhythmia, you have to go and apply sodium bicarbonate immediately. Very important. So they could be having seizures. Give them benzo. Like lorazepam. So people with streptokinase toxicity, give them aminocaproic acid, to prevent the bleeding, because there's going to be too much bleeding. So tranexamic acid or aminocaproic acid. So for warfarin toxicity, just give them fresh sodium plasma, for immediate reversal, fresh sodium plasma. In fact, if you have PPC or PCC, that's the best. But if you don't have PPC or PPCC or something, PCC, if you don't have PCC, just give them fresh frozen plasma. But if you have platelet concentrate, prothrombin complex concentrate, PCC, give them that. If you see fresh frozen plasma, give them that. Then for long-term reversal, you can also administer vitamin K. All right. So, do you have any question so far? Any question, anybody? Before we call it a day. Any question, anybody? Okay, no question. So